We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 30 of AMOGS Emergency Obstetrics Committee with TNFOG. So it's my privilege to introduce the MOC of today's webinar, Dr. Priya Kannappan ma'am. Ma'am is the consultant obstetrician and gynecologist at Mehta's Hospital, Chennai and Garbha Rakshambikai Fertility Center, Chennai. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahati. Thank you. So I would like to welcome all of you on behalf of TNFOG and the AMOGS to this webinar. So we have very interesting sessions planning. So can we have the CD deck if that's okay?
Hello.
Let us
Yes, sir. Hello, sir.
Video
and welcome.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Sahiti, you have stopped that. Can we go? Go ahead.
Yeah, go ahead, Priya.
Yes, ma'am. So it is my pleasure to invite Dr. Sneha Madam. So Sneha Madam, a very good friend of all of us who are here and most of our delegates as well. She has been an International MS Signatory Award for Phenomenal Leadership 2020, Asia GCC Award 2021, Dr. S.N. Malhotra Individual National Award for Outstanding Work in a Rural Obstetrics 2008, Dr. Durusha's Distinguished Community Service Award 2022, Individual Award Championship of the Foxy Award for 2 consecutive years, 2020 and 2021, and the Dira Award for 2022. Anandibai Joshi State Award by the Government of Maharashtra, Lokmat Healthcare Excellence Award 2020, 300 plus talks, 10 plus keynotes and orations, and moderated more than 100 plus panels. And she has 30 chapters and articles in national publications. She is a candidate for the Vice President Foxy West Zone and the Foxy Breast President Committee Chairperson 2019-2021, GCM ICOG 21-22, National Adolescent Trainer WHO FPAI Certified, National Expert of the UNICEF.
Thank you, Dr. Priya.
Over to you, madam. Over to you, ma'am.
Thank you so much, Dr. Priya, for not only the introduction, but coordinating this program so well. A very good evening to all of you. My respect and regards to all the respected seniors here, especially respected Dr. P.K. Shah sir, Madam Suchitra Pandit, who are the chief guests for today's program, and of course, Madam Anjalakshi and Madam Sampath Kumari, who are the guest of honor for today's program. I welcome all of you on behalf of the entire team of AMOGS. I welcome the AMOGS office bearers, especially Dr. Kiran Kurtakoti, President, Dr. Bipin Pandit, the Secretary, Dr. Rajendra Singh Pardeshi, the immediate past President of AMOGS, and of course, Dr. Madhuri Mendar, the Treasurer. I welcome Dr. Ramani Devi, Madam, who is the President, and Madam Sampath Kumari, who is the Secretary of TNFOG, and of course, Dr. Sarvana Kumar. I'm very happy to host this program with TNFOG. As I have been talking about right from when I was a breast committee chairperson, we have started this series and it's ongoing since, even the entire TNFOG, all the societies we have covered. This is almost the last program of this series, I would say. So I welcome all the esteemed faculty, especially Ramani Devi, Madam, and of course, Dr. Shanti Rani. Madam will be speaking on cardiac problems in pregnancy, and I'm sure all of you are well versed that Madam has a special affection, I would say, and a special privilege for all of us to listen to her on this issue. I think we get more information because of sir. I think that is our privilege to listen to you, Madam, especially, and of course your experience definitely matters.
Hello.
Dr. Shanti Rani will be
Anjalakshi madam
speaking
has
on
come,
the
Sneha.
management of hypertensive crisis, and I will be moderating the panel discussion on immediate complications of hypertensive disorders of pregnancy. I'm very happy to welcome all the respected chairpersons for today's program and all the panelists, Dr. Jaymala, Dr. Bharti Rajsekhar, Dr. Anita Rajoria, Dr. Chandrakala Maran, Dr. Sujata Alaksen, and Rashmi Ajit, Dr. T. Chitra from Puducherry, Kavita Abraham, Dr. R. Renu, and of course, Dr. Priya Nappan and Dr. Sahiti, not Dr. Sahiti, but Sahiti. So I'm very happy to have this program, and thanks to both the organizations. With this, I would like to welcome today's chief guest and have his blessings and, of course, words of wisdom. I would invite Madam Suchitra Pandit first as the CV is displayed. Madam is my mentor since long. Of course, not only just for the sake of saying, Madam has literally handheld me right from the beginning of my journey in FOXY. Madam is the past president of FOXY, NCC, RCOG, and National ISOPUB as well. Of course, India Justice Chapter India. And Madam has been, of course, the president of AMOGS and so many other posts and awards and accolades she holds. And she's really inspiration for all of us. So we would like to listen to you, Madam, for your precious words.
Thank you, Sneha. First of all, this is, I think, the second time or the third time I'm coming for your program. And I see that today is the 30th, which means that you have actually completed 29, which is a lot of hard work. So the AMOGS Emergency Obstetric Committee, I think, conducts practical programs which are going to be useful for all the people who are listening. And particularly when I see today also that she has a panel on the complications of HDP, and also we have Ramani Devi speaking on cardiac disease. So well chosen topics. Each time there is something or the other new happening. And it's important for people to be well versed with these conditions. And also because through your emergency obstetric committee, you're able to cover the entire Indian societies, and now the TNFOG is there. So it's good that you're trying to spread the knowledge far and wide. And I know you've done tremendous amount of work as chairperson of the breast committee, and I know the wonderful public health program which you've also done. So I think you're an absolutely apt candidate for vice president, and I know that you will win definitely. But I request all the listeners and everybody to make sure that that first vote that you're going to put in is going to be for Dr. Sneha Bhuyad. Sneha, all the best. And once again, lovely to share this podium with Dr. P.K. Shah, Dr. Anjalakshi Madam, Dr. Pardesi, Dr. Kiran Kurtukoti, and Dr. Bipin Pandit, and of course all the wonderful faculty. I don't see any of the panelists right now, but I would like to say a hello to all of them and wish Bharti Rajsekhar, who's also contesting for the post of a chairperson. Of course, their elections are much more later. But friends, once again, thank you very much for having me over. And please don't forget to vote. From the 1st of August, your voting is going to start. So make sure that you show your loyalty to FOXY by voting, and make sure you vote for Sneha Bhuyad as your first vice president. Thank you very much.
Thank you so much, Madam. Thank you for your blessings always, of course. So much to learn from you, Madam. Respected Dr. P.K. Shah, sir, what to say about you, sir? I have been learning so many things from you. Everybody, I'm sure, not only as past president of FOXY, people know you being a very illustrious academician and a very illustrious personality, though the CV is highly decorated. I would just say a few words about you, sir, that you are, for you, I would say age is just a number, and so much to inspire from you, sir, that even at this age, you keep teaching and teaching all of us, spreading knowledge and making everybody aware of all these obstetric complications, especially, I would say. And we would like to rather listen to your precious word than reading all this. So over to you, sir, for your precious words.
Thank you, Sneha, for your kind words. At the outset, let me thank AMOG's office bearers, Dr. Kiran Purtukoti, Dr. Bipin, Dr. Rajendra Singh Pardesi, Madhuri, and obviously Chairperson of Emergency Obstetrics Committee, Dr. Sneha Buyar, for making me a part of this particular webinar. Also, along with TNFOG office bearers, Dr. P. Ramani Devi, S. Sampat Kumari, and Dr. Sarvana Kumar. I think you started this series, probably I was the first one, I'm not sure, I don't remember. But either Suchitra or myself, we were the first ones as chief guests for this series, which have been running for quite some time. Let me tell you, Rajendra Singh Pardesi, I don't know whether in AMOGS you have any prize or award for the best committee in AMOGS or not, but I think Sneha deserves the best committee award from AMOGS. The amount of work that she has done, I see almost every weekend there is something or other going on her side. Okay, she's fighting for election, that's a different issue altogether. But putting in so much efforts, not only this year, but also last year, we have been hearing her for quite some time. And as Dr. Suchitra said, she deserves to be the vice president of FOXI. And again, I request all the members of FOXI to support her positively and see to it that she gets elected as vice president. Nice to see Dr. Ramani Devi, who is also contesting for vice chair's post of ICOG. Dr. Bharti Rajshekhar and Dr. Anita Rajoria both are also contesting for chairperson's post of FOXI. And I wish both of them all the very best and success.
Thank you.
So nice topics have been picked up, the cardiac diseases in pregnancy and hypertensive crisis in pregnancy. And also again, the panel is going to be complications of hypertensive disorders, which is going to be conducted by Sneha herself and very esteemed members of FOXI from various societies of the South. So I think again and again, I have fallen in love with this society, this committee of yours. And I hope, and I have a feeling that whosoever takes over after you finish your tenure as chairperson of this committee, I don't know what will happen. There'll be a vacuum, I feel, because the way you have been working, I think there is no parallel. And I wish you all the very best from the bottom of my heart. And we would like to see people like you who are hardworking to be in FOXI. Thanks a lot and all the best.
Thank you, sir. Thank you so much. Your blessings mean a lot to me, sir. Definitely, elections will continue, and I will, whether I'm in election or no, I will continue to work hard,
Wow.
sir. Thank you so
Nice
much.
to hear that.
Thank you, sir.
Sneha, can I
yes,
just take 1
please,
minute and
please.
wish Dr. Ramani Devi also all the best for her elections, because she's also contesting for the chair of ICOG. And Dr. Rajouri, I saw her briefly, but then I didn't see her afterwards.
Yeah, she's
So
very much
best of
there.
luck to all of
Thank
you
you.
all for
Anita is
your
there.
elections.
And Dr. Bharti Rajshekhar.
Yes,
Bharti is
Bharti,
not
I
joined.
already saw her.
Bharti,
So
I
congratulate
don't
her.
see Bharti anywhere.
Oh, she's supposed
I wished her in the beginning.
But she's not to be seen.
yeah. Panelists, some of the panelists are yet to join.
Yeah.
Thank you, madam, and thank you, sir. So now I would like to invite Dr. Anjalakshi, madam. Madam, I hope your problem with the audio is sorted out.
No, I have opened with the cell phone.
now we are clear, madam. Now it is clear.
Okay, voice will be heard, but the video is not working there. Okay, there's no problem. Sorry, extremely sorry about that.
No
The
issues, madam.
laptop is giving trouble now.
No problem, madam. Madam, we know you since so long, and in fact, you are the one who initiated this series along with FOXI Breast Committee. So we are really very thankful to you, madam. And as president of TNFOG, you are the founder president of TNFOG. You are the past president of FOXI, and of course, past president of DIPSI. You have a PhD in pregnancy diabetology from Tamil Nadu, Dr. MGR University, and You are the former professor and head of SRM Medical College,
Enough, Sneha.
College, and yes, so many colleagues to your credit, madam. We are very happy and fortunate to have you as our guest of honor. We would like to listen to you and your precious words, madam.
Thank you, Sneha, for this kind introduction. Good evening to everyone. Respected Chief Guest Dr. P.K. Shah, dear Dr. Suchitra Pandit, and my co-guest of honor, Dr. Samvat Kumari, office bearers of the AMOGS, office bearers of TNFOG, the speakers, Dr. Ramani Devi and Dr. Shanti Rani, panel moderator, Dr. Sneha Buyar, and my dear panelists and delegates. It gives me immense pleasure and proud privilege to be the guest of honor along with the legends like Dr. P.K. Shah and Dr. Sujitra Pandit for the webinar on emergency obstetrics episode 30, focusing on cardiac disease in pregnancy and hypertensive crisis. I congratulate both the AMOGS and the TNFOG for choosing this important topic. I thank Dr. Sneha for this wonderful opportunity. And coming to the subject, the heart disease during pregnancy, it has emerged as a major threat to the safe motherhood and the women's long-term cardiovascular health. And it is the leading cause of death in pregnant women, which has increased from 7.2 per lakh in 1987 to 17.3 in 2018. And the developed countries, the cardiac disease is the most common problem for the maternal mortality. Cardiac disease during pregnancy may be an exaggeration of pre-existing condition or may develop by a new disease process that presents because of the complex hormonal changes and the physiology of pregnancy, which includes like hypertension, gestational diabetes, peripartum cardiomyopathy, and congenital heart disease. Cardiomyopathy are responsible for 26% of all pregnancy-related deaths. And rheumatic heart disease still is common in India and other developing countries, despite the dramatic improvement in survival and quality of the life of patients with severe congenital defects and other disorders. Pregnancy remains inadvisable for women with certain high-risk conditions such as pulmonary hypertension, coarctation of aorta, Marfan syndrome, and severe aortic and mitral stenosis, and also the cardiomyopathy. To manage these conditions, it involves the interpersonal team and the pre-pregnancy counseling. And many people, they are postponing their pregnancy to fourth and fifth decade, which was made possible by the IVF therapies. This increases the incidence of acquired heart disease like coronary artery disease, hypertension, diabetes, and arrhythmias. So the heart disease during pregnancy can pose an unique challenge, and updating ourselves with the multidisciplinary team will help to improve the outcome and reduce the mortality to our women folk. In Chennai, our dedicated cardiologist, Dr. Justin Paul, he has started a registry for heart disease complicating pregnancy, and he has also created a WhatsApp group where you can discuss the difficult cases and give the care as per the international standard. And to discuss on this, we have very apt person, Dr. Ramani Devi, who is managing many cases of heart disease complicating pregnancy with her expert husband, who is a renowned cardiologist. So there will be a lot of learning from Dr. Ramani Devi. And the next topic is the hypertensive crisis in pregnancy, which is one of the cause for the deadly triangle of maternal mortality, and followed by a panel on immediate complications of hypertensive disorders. So the learning is going to be very large today, and I wish the webinar a grand success and my best wishes. And I thank once again for this wonderful opportunity. By the way, my best wishes and for the success of the in the coming elections for Dr. Sneha Buyar, Dr. Ramani Devi, and Dr. Rosaria and Bharati. So my best wishes for all of you to win in the elections and do your best for this FOXY and the TNFOG. So once again, I thank for this wonderful opportunity. Jai Hind. Thank you.
Thank you so much, madam. Thank you so much for everything, I would say. And I don't think Dr. Sampath Kumari has joined.
Yes, I called her, madam. She said she'll join, but maybe a
So
little
whenever
later.
she joins, we will have her words, of course. Even AMOGS President Dr. Kiran Kuttakoti has not joined, I think. So I would straight away invite Dr. Rajendra Singh Pardesi, who is the immediate past president of AMOGS. And so all of you know, sir, as a very
You can skip that.
yes,
Yeah, you can
gentle
skip.
human being, and of course a very helping personality. So definitely we would like to hear from you, sir, your words of wisdom. Over to you.
Good afternoon, everybody. Respected chief guests and my mentors from Sion Hospital, Dr. P.K. Shah sir and Dr. Suchitra Pandit ma'am. They both are my mentors. Guest of honors, Dr. Anja Lakshmi Chandrasekaran, Dr. Sampath Kumari, our AMOGS President, Dr. Kiran Kurtakoti, TNFOG President, Dr. Ramani Devi, and Kasoga President, Dr. Bharti Rajsekar, and friends, panelists, and chairperson. Feeling proud and honored to be a part of this webinar, and that webinar with TNFOG and Kasoga also. And Dr. Bharti Rajsekar is there, so I think Kasoga is also there. And this will definitely help in reducing maternal mortality, as Dr. Anja Lakshmi explained. And with the involvement of faculties like Dr. Ramani Devi, Dr. Shanti Rani, Dr. Sneha Boyar, Dr. Chairperson and panelists, I think this is going to be a great event. I wish to congratulate Dr. Sneha Boyar for this. I wish every success to Dr. Sneha Boyar for her future endeavor in FOXI, as she is contesting for the post of Vice President FOXI. As Dr. P.K. Shah told, she deserves this post and we all should support her. I wish every success to Dr. Ramani Devi also, as she is contesting for the post of Vice Chair ICOG. She is a hardcore academician, and I wish every success to Dr. Bharti Rajsekar also for her future endeavor in FOXI, as chairperson of Perinatology Committee, as Dr. Anita Rajora is there. I wish every success to Dr. Anita also for her future endeavor in FOXI, as chairperson of Environmental Health Committee. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much for your words of wisdom, and of course your blessings and your best wishes mean a lot to us. Thank you so much. With this, I thank all the respected dignitaries, Dr. P.K. Shah sir, Madam Suchitra Pandit, Dr. Anjalakshi Madam, of course, Dr. Sampath Kumari, who will be joining soon, Madam Ramani Devi and Dr. Shanti Rani as speakers, and all my esteemed panelists whom I have already welcomed. I thank all of you, and without much ado, we would like to go ahead with the academic session, and I hand over this forum to you, Dr. Priya, for the further proceedings. Thank you so much once again for gracing this occasion. Thank you so much.
So thank you, everyone. Thank you, Chief Guest, and thank you, Chairpersons. Thank you, Guest of Honors. So thank you, everyone, for joining the inauguration. Now, it is my pleasure to invite Dr. Ramani Devi, Madam. Madam is a National Vice President FOXI 2020, International Advisory Board Member for Fertility Society of Bangladesh, ICOG Governing Council Member 2018-20.
Yeah, Priya, we are running short of time. Just
yes, ma'am. Madam is the President of TNFOG, and Madam is also contesting for the ICOG elections. So over to you, Madam, for the talk on the cardiac disease in pregnancy.
Yes, all our best wishes, Madam.
Thank you. Are you able to see my slides?
Slides are visible, Madam. Yes,
Yeah,
ma'am.
yeah. Good evening, respected Chief Guest, Dr. Suchitra Pandit and Dr. P.K. Shah, the guest of honor, Dr. Anjalakshi Madam, as well as the AMOGS office bearers, Dr. Kiran Kuttakoti, Dr. Pipin Pandit, Dr. Rajendra Singh Pardesi, and Dr. Sneha Boyar, who has been very much involved in me participating in this particular program along with the TNFOG. And I think it is a great honor for me to give my talk on cardiac disease and pregnancy in this platform. Thank you, Dr. Sneha. Also, thanks to all the seniors for your blessings that are showered upon me towards the elections. Thank you so much. Now let me start the topic, cardiac disease and pregnancy. See, the incidence of heart disease, it varies between 0.4 to 4%, average of 1%. Pregnancy with heart disease has increased, and especially in the developed countries, the rheumatic heart disease is decreasing, but whereas congenital heart disease with pregnancy is increasing because of the support that is given by the cardiologist, so that the lifespan of the women with congenital heart diseases increases. And again, total MMR due to heart disease has decreased, but in developed countries, the relative MMR due to heart disease has increased from 7.2 to 17.2, because we know very well that the incidence of PPH and hypertensive disorders are relatively coming down, so that there is a relative increase in the heart disease complicating pregnancy. Then why there is the reason, what is the reason for increased maternal mortality rate among heart disease patients? One is, most of the patients with the heart disease, they not only this valvular heart disease, but it can be in the form of arrhythmias or hypertensive disorders or cardiomyopathy. They are all in the increased advanced maternal age, and comorbidities like diabetes, hypertension, and women with congenital heart disease, they reach the age of reproduction, and there is definite racial and ethnic variation. For example, it is highest in the Black non-Hispanic women compared to the Hispanics. But whereas when you say the maternal mortality in the US, because of the cardiac complications during pregnancy is very much low. But whereas in the underdeveloped countries and in the developing countries, the incidence is quite high. See, if you see the US maternal deaths 2011 to 15, 1 week to 1 year postpartum, 33% they die in the postpartum, 31% during pregnancy, and 36% during delivery or 1 week later. And the heart disease and stroke caused more than 1 in 3 deaths. And Black Americans, Indian, Alaskan Native people, they are likely to die 3 times as a compared to the white women. They have a 3 times higher incidence of maternal death. Now let us come to the topic. There are certain normal and adverse cardiac clinical symptoms and signs during pregnancy. The usual symptoms and signs of during normal pregnancy are: any patient tends to have hyperventilation, breathlessness on exhaustion, intermittent palpitation, mild fluid retention, mildly elevated JVP, third heart sound, soft systolic murmur, resting tachycardia. All these things are found normally in any pregnant woman. But whereas in a woman with a cardiac pathology, the woman is extremely breathless, she may complain of chest pain, orthopnea, PND, nocturnal cough. They are all very specific to women with specific heart disease. And again, tachycardia, it is always beyond 100 beats per minute. And fourth heart sound is heard, and harsh systolic or diastolic murmurs are heard. Diastolic murmurs, if they are present, it is definitely indicative of a organic lesion. Then pulmonary edema and pleural effusion. These are all the signs and symptoms. Coming to the types of heart disease, what you can come across during pregnancy is, though the heart valvular lesions are the commonest, but now the incidence of valvular lesion is actually coming down. And the congenital heart disease is comparatively increased because the women live up to that year. Then the third one is the coronary artery disease, where in women who are undergoing ART at the extremes of, nearing perimenopausal age, they are likely to have CAD, and that may be the presenting factor during pregnancy. Again, abnormal cardiac rhythm in the form of arrhythmia or heart failure. Heart failure is a condition where the heart is not able to pump the blood, and it can happen secondary to valvular lesion or secondary to myopathy. And heart muscle problem is invariably, it can be because of hypertrophic obstructive cardiac myopathy or dilated cardiomyopathy. So then, according to etiology, the same thing: congenital heart disease, cyanotic, acyanotic, acquired is rheumatic heart disease, cardiomyopathy or congestive heart failure, ischemic heart disease, myocardial infarction, hypertensive cerebrovascular disease, arrhythmias, and hypercholesterolemia. So now the hemodynamic changes, what happens during normal pregnancy, I think all of us are aware. There is increase in the plasma volume, increase in the cardiac output, increase in the heart rate. The mean arterial pressure also slightly increases. Stroke volume increases, systemic vascular resistance is reduced, and pulmonary vascular resistance is decrease. So this is a pictorial representation where you can see the increase in the cardiac output. The blood pressure initially at the end of the first trimester and the beginning of second trimester, it falls down, it reaches the baseline at the end of third year. Again, third trimester, again, the heart rate starts increasing and systemic vascular resistance and pulmonary vascular resistance are reduced. So now let us see what are all the symptoms of heart disease in any pregnant woman. They will say jaw, neck pain, chest pain, and back pain. There may be shortness of breath, fainting attacks, nausea and vomiting will be there, indigestion, and extreme fatigability and discomfort in the epigastric region. Most of the patients who are suffering from myocardial infarction, they present initially only with the discomfort in the epigastric region and indigestion, which ultimately radiates towards the left arm. So what are the clinical findings in the heart disease? So clinically, sometimes if the patient has got a cyanotic congenital heart disease, they can have cyanosis, clubbing of the fingers, persistent neck vein distension, systolic murmur of grade 3/6 or greater, diastolic murmur of any grade, cardiomegaly, persistent arrhythmia, and persistent split-second sound. So these are all the clinical findings. Then the other two important things to diagnose any lesion, cardiac lesion, is the ECG and the echocardiography. ECG will tell you the abnormal electrical conduction, especially it is useful in arrhythmias, detecting the arrhythmias of varying causes, and the mechanical that is being picked up by the echocardiography, and rarely, very rarely, we go in for a cardiac catheterization. All of you would have known that in Tamil Nadu, every antenatal woman is advised to have an echocardiography, and it is invariably done at all the medical college hospitals and even in the district district hospital, so that the women who are pregnant are thoroughly screened for the basic cardiac disease. And preferably, instead of doing it at the mid-trimester, it should be done at the early trimester. That is according to me, because if you are able to pick up some of the cardiac lesions which are not compatible with pregnancy, maybe termination may be made easier. And again, some of the correctable lesions, suppose if the patient has got a tight mitral, then the patient can be planned for a balloon mitral dilatation soon after first trimester. So that is the advantage of doing it in the first trimester. And if the patient is presenting with persistent symptoms, maybe the patient may need a repeat echocardiography at the late trimester. So now we need to manage this particular patient with a cardiac disease. We need an expert group of doctors. A single doctor, obstetrician alone cannot do it. We need a patient obstetrician who has got an expertise in cardio-obstetrics, cardiovascular medicine cardiologist, fetal medicine consultant, obstetrician, primary care physician, anesthesiologist, nursing care, pharmacy, social worker, and other specialists or even cardiothoracic surgeon. They are needed and they form a part of the cardio-obstetric team and the patient. Now here, the model care starts preconceptionally. There should be preconceptionally, patient should be advised contraceptive advice in certain conditions where pregnancy is contraindicated, for example, primary pulmonary hypertension or asymmegas. Again, all should be optimized regarding the medical status, medication adjustment. For example, if the patient is on some of the antihypertensive drugs like AC or ARB inhibitors, they should be changed. And then risk assessment based upon the WHO criteria, Corporate 2 criteria, and Sahara criteria should be done. Again, during pregnancy, it should be a team and serial monitoring, delivery planning, and balancing the maternal and fetal risk are needed. And during labor and delivery, the mode of delivery, preferably it should be a vaginal delivery. And if the regional anesthesia may be safe or epidural may be safe to reduce the pain as well as reduce the tachycardia, etc. Then monitoring, if the patient should be continuously monitored with a pulse oximetry, and if needed, she can have a continuous ECG monitoring. During the postpartum period, the labor should be cut short by using vacuum or forceps. And C-section is indicated only in obstetric indication. Postpartum period, minimum of 48 hours, the patient should be kept in the HTU or ICU, and they should be watched for cardiovascular complications. And the fourth trimester, that is day 3 to day 7, post discharge follow-up is very, very essential, and comprehensive evaluation within 6 weeks has to be done. And hence the patient needs additional visits, or at least telemedicine visits are needed. And they should be definitely advised regarding contraception. So beyond this, we have a long-term complication. So any woman who's identified with adverse pregnancy outcome, that is, for example, a woman during pregnancy is having a preeclampsia, eclampsia, or hypertensive disease, or a gestational diabetes, or a preterm labor, or small for gestational age, this woman is likely to have a high risk of developing cardiovascular as well as cerebrovascular lesion, and then in future, and they need to be advised regarding periodic screening. So this is the first New York Heart Association functional grading. All of us are very familiar one. Class 1 is no symptoms with normal physical activity, no normal functional status. Class 2 is there may be mild symptoms with the normal physical activity, comfortable at rest, but slight limitation of the functional status. Class 3 is a moderate symptom, less than the normal physical activity, comfortable only at rest, but even a smaller action it can limit the functional status. Again, class 4 patient has got severe symptoms, features of heart failure, and restricted physical activity even at rest, and severe limitation of the functional status is there. So class 1 and class 2 are quite safe. These women can undergo continue the pregnancy. Now, according to the risk, if it is going to be low risk, that is 0 to 1%, AST, VST, PDA, mitral stenosis, mild, and corrected fallow, they all come under low risk category. And medium risk is between 5 to 15%, that is MMR rate. Moderate to severe mitral stenosis with atrial fibrillation, aortic stenosis, uncorrected fallow, they come under the medium risk. High risk is pulmonary hypertension, Eisenmenger's, aortic coarctation with a valvular involvement, Marfan's with aortic root dilatation. They all carry a very high risk during pregnancy. CAR-PREG index is nothing but it will calculate, it will give you some points, some predictors are there, prior cardiac events, baseline, New York Heart Association 3 or 4 or cyanosis, mechanical valves, ventricular dysfunction, and then high risk of left-sided valve disease, left ventricular outflow tract obstruction, pulmonary hypertension, CAD, high risk iotopathy, that is root dilatation, what we see in Marfan's, and no prior cardiac intervention, late pregnancy assessment. All these things are given certain point. And if there is a higher point, that means the patient is at a high risk of developing complication. Then comes the Sahara score, which is mainly done for the congenital heart disease. Here again, based on the arrhythmias, New York Heart Association classification greater than 2, then left heart obstruction, cardiac medication before pregnancy, systemic AV, valve regurgitation, or pulmonary regurgitation. So again, each predictors are given some points, and the total point is about 0 to 3. Suppose if the patient has got a 0 point, then the risk is about 2.9%, and as it increases, say 0.5 to 1.5 to 7.5, but when it comes to more than 3.5, the risk total point, then the risk is going to be 70%. So then the WHO has modified, simplified that, and classification 1 is previously diagnosed hypertension, diabetes, obesity, successfully repaired simple lesions like AST or VST, uncomplicated small mild mitral valve prolapse, pulmonary stenosis, and palpitation without dizziness. So that comes under the classification 1. And modified WHO classification 2 is unoperated AST, VST, repaired fallow, coarctation, arrhythmia with dizziness, mild LV impairment, that is, it is always beyond more than EF, ejection fraction is more than 45%, and newly diagnosed peripartum cardiomyopathy and hypertensive cardiac failure. Previously diagnosed rheumatic heart disease with murmurs are recently assessed asymptomatic mechanical bone. So the severe WHO class 3 and 4, the mechanical valves with symptoms, complex congenital cyanotic heart disease, primary pulmonary hypertension, or any form of hypertension where secondary to reversal, and previously diagnosed peripartum cardiomyopathy where the left ventricular impairment is less than 45%, severe mitral stenosis and aortic stenosis, or when the aortic root dilatation is greater than 45 millimeter or Marfan's. So what is the effect of heart disease upon pregnancy and vice versa? See, upon the baby pregnancy, it can lead to abortion, preterm labor, IUGR, teratogenicity, and you can have the chances of getting the baby getting congenital heart disease about 5% in a mother who has got a congenital heart disease, intrauterine fetal demise, and as well as upon the mother, it can worsen the cardiac situation, CCF, bacterial endocarditis, pulmonary edema, pulmonary embolism, rupture of aneurysm, and there will not be any long-term effect upon the basic defect that continues. So what are the critical periods where the patient should be carefully monitored? The changes starts occurring at 6 weeks, maximum changes occurs around the 30 weeks, intrapartum period soon just after delivery and second week of puerperium. So what are the poor prognostic indicators? History of heart failure, coronary ischemic heart disease, stroke, arrhythmias, and patients on anticoagulants, mechanical valves, and grade 3 and 4 NYHA classification, mitral valve area when it is less than 2 square centimeter, or AV valve ratio area below 1.5 to 2 square centimeter, and ejection fraction when it is less than 45%. There are additional risk factors which can be modifiable. For example, correction of anemia, correction of infection, hypertension to be controlled, physical labor should be avoided, weight gain should not be there, multiple pregnancy, it poses a higher risk in patient who has already got a cardiovascular disease, intake of caffeine, alcohol, pain, as well as drugs like when tocolytics are used in a cardiac patient, we have to be very careful because it can precipitate pulmonary edema. And the preferable tocolytic is not a beta mimetic, but we can go for a atazibon or calcium channel blockers. So now the preconceptional counseling, the obstetrician, primary care provider, cardiologist, and emergency room physician. So the first referral by the consultant is, the obstetric consultant is, we have to have a teamwork. So what we have already mentioned, and the patient should have a detailed cardiac evaluation, and cases with arrhythmias, they can have a Holter monitoring, etc. So the shared decision making between the consultants and the patient should be made, and all medication should be reviewed. For example, AC inhibitors and oral anticoagulants, there should be altered when the patient becomes pregnant, and all corrections of this anemia correction, folic acid supplementation, iron, B12, and micronutrients should be supplemented. In the antenatal care, should be much more vigilant than the normal non-cardiac patient. And first thing is we have to have a clear counseling, antenatal care every 2 visits up to 30 weeks. And again, each visit, you have to note the pulse rate, BP, cough, dyspnea, weight gain, anemia, and all the auscultation and re-evaluation of the functional grade. Ensure the treatment compliant. And then exclude fetal congenital anomaly by level 3 ultrasonogram, especially as I mentioned in a mother with a congenital heart disease. Fetal monitoring, atazibon is better than any other beta mimetic. Special advice: rest, avoid undue excitement, diet with iron and vitamins, and hygiene. Regarding hygiene, dental care should be there. Restrict salt, avoid smoking, drugs like beta mimetic should be avoided. Avoid air travel, and then when you have to diagnose and treat the PAH and infections as early as possible, and therapeutic and prophylactic cardiac interventions as applicable. And the patient has to be put on benzathine penicillin or some form of endocarditis prophylaxis should be given, and diuretics, beta blockers, digitalis, and anticoagulants, and surgical treatment whenever is possible. For example, tight mitral, the patient can very comfortably undergo balloon mitral valvotomy during the second trimester. Now, suppose if the patient has got up, we have to get the patient admitted by when there is a peak cardiac output at 32 weeks of gestation. And in patients with severe cardiac decompensation, the patient has to get hospitalized then and there. Then if the patient gets into preterm labor, hospitalized, no beta mimetic or nifedipine, better is to give atazibon. Steroids have to be given. Follow the protocol for preterm labor. In utero transfer is very ideal. Late preterm, like beyond 32 weeks, if they have a present with preterm labor, maybe they can manage as per the cardiac protocol, because the chances of neonatal death may not be as high. Then the question is where to deliver. According to WHO, 1, mild pulmonary stenosis, PDA, mitral valve prolapse, repaired AST, VST, PDA, and then once are follow-up during the hospital and during pregnancy, periodically in a local hospital, and local hospital can deliver. But whereas WHO type 2 classification 2 also, unrepaired AST or VST without any reversal, and repaired TOF with Turner syndrome without aortic dilatation, and follow up during pregnancy every trimester in a local hospital, and delivery can be there. Then again, class 2 to 3 WHO with a mild left ventricular impairment where there is ejection fraction is beyond 54, and native or tissue valvular disease replacement, or Marfan syndrome, aortic bicuspid aortic valve, repaired coarctation. All these things they should deliver in an expert position. And class 3, WHO class 3 classification, where there is reduced LV function, mechanical valves, and then Fontane's operation done, few unrepaired cyanotic disease, moderate mitral stenosis or severe asymptomatic aortic stenosis, and all these patients, high-risk patients, should deliver in an expert center. Then indications for admission, New York Heart Association classification 1 and 2, before delivery, EDC. Preferably by 36 weeks, they have to get admitted. Class 2, 28 to 30 weeks, where there is a peak cardiac output is high. 3 and 4, irrespective of the period of gestation, as soon as the patient comes, they have to get admitted. Now, to change from oral anticoagulants to heparin in early pregnancy and 36 weeks in patients on anticoagulant. I will discuss about the changing to anticoagulation during the first trimester in my subsequent slide. Then indication for admission is emergency when there is deterioration, or when the patient has got other complications like fever, UTI, or dental problem, or the patient presents with pulmonary edema, anemia, infection, PAH, or abnormal vein gain, or other medical disorders. So only institutional delivery. Induction of labor is only for obstetric indication. And ideal thing is you can use an intracervical Foley installation, especially in congenital heart disease. PG gel may be employed. Vasodilatation, it can cause and use with caution. So in my experience, I personally feel if you want to induce a labor in a cardiac patient, ideal is a intracervical Foley installation. Then how do you manage in the first stage of labor? Confined to bed or propped up position or semi-recommend, oxygenate, maintain the SiO2, then give a sedation or analgesia, epidural or pethidine or tramadol. And we have to be very cautious in using IV fluids. Preferably, you increase the oral fluids and reduce it. Stop anticoagulants, and it should be 24 hours prior to induction of labor. Digitalize if there is CCF. Diuretics can be liberally used, especially as soon as the patient delivers. Diuretics should be given to reduce the pulmonary load. Then bronchodilators if needed. Endocarditis prophylaxis. Cardiac monitoring, I have already mentioned. Continuous ECG monitoring with pulse oximetry. And then availability of anesthetists and cardiologists is a must. Then endocarditis prophylaxis for whom you will give. So it should be given for congenital heart disease, rheumatic heart disease, prosthetic valves, hemodialysis, and patient when she is on immunosuppression or intravenous catheters. All these patients, they need endocarditis prophylaxis, and just a simple case of mitral valve collapse with the minimal MR, they don't need an endocarditis prophylaxis. And the drug that is usually given is ampicillin 2 grams IV/IM plus gentamicin. And 6 hours later, you can give either ampicillin oral IV/IM or peroral route. In case of allergy to penicillin, maybe we can switch over to vancomycin or clindamycin plus gentamicin. So how do you manage the second stage of labor? It is like this. The patient should either deliver very comfortably, or in cases of doubtful cases where you think that the labor is going to be prolonged, better you take the patient for a planned C-section. So delivery should be in a propped up position, avoid forceful bearing down, adequate pain relief either by epidural, spinal, or saddle block, cut short second stage, and liberal episiotomy, vacuum forceps, and are not always. Suppose if the patient is able to push out with minimal effort, then that may be safe. Otherwise, cut short with the forceps or vacuum. And strict cardiac monitoring should be there. And soon after the delivery of the fetus, we have to give a diuretic. So the third stage is very, very important. Amstel, 10 units oxytocin should be given IM. Avoid bolus oxytocin or ergometry, no ergometry. Propped up position, oxygen inhalation, furosemide, pethidine. Watch for signs of congestive heart failure and pulmonary edema. To treat PPH energetically, mechanical methods like bimanual compression and wheelage sutures can be done. And mesoprost's rectally is much better than carbopros. So first 1 hour is very, very important post-delivery where the patient should be in a propped up, comfortable position, oxygen SOS, and watch for the signs of pulmonary edema and watch for tachycardia and give adequate antibiotics. As I said earlier, the indications for C-section are only obstetrics, and in the cardiac case, coarctation of aorta, Marfan's with a dilated root of aorta, preferably you can do C-section under epidural analgesia. Narcotic conduction analgesia can also be given, and general anesthesia and pulmonary hypertension and in patients with intracardiac shunts. So advice at the time of discharges, we can promote lactation. That is not a contraindication. Continue medical management, avoid infection, reassess after 6 weeks or if earlier, and preferably these postnatal mothers should be watched by the village health nurses during their home visit. Proper iron supplementation, avoid infection. Cardiological consultation is a definitive management of the heart disease soon after delivery, maybe after 4 to 6 weeks. Promote breastfeeding and contraception we have to advise. So these are some of the postpartum red flag signs, namely chest pain, tachycardia, dyspnea, orthopnea, cough, edema, headache, non-vagal syncope, and visual changes, hypotension and hypertension. So the 4th trimester is we have to address each of the problems, then counsel this women for the long-term problems as well as regarding lactation, reduce stress, and regarding family planning, and treat if they have associated hypertension, GDM, chronic CVD management, mental health, and refer to a social and a primary healthcare physician. And then screening and follow-up is very, very essential. And definitely you have to have some advice regarding contraception. Postpartum complications can be cardiomyopathy is known to occur during the last 1 month as well as first 5 months immediate postpartum period. Pulmonary hypertension and hypertensive diseases can be the condition. These are the conditions, they increase the risk. Obesity, they increase the risk of postpartum complication, and potential cardiovascular complications are heart failure, stroke, thromboembolism, aortic dissection, hypertension, arrhythmia, and CAD. Suggested monitoring is we have to monitor the patient, high-risk patient, for at least for 48 to 72 hours, monitor them for watch for cardiac failure, watch for pulmonary edema, and watch for arrhythmias. And of course, if needed, we can go for a postnatal echocardiography to assess the LV function. So what are the cardiac contraindications to pregnancy? I will say the first main contraindication is severe primary pulmonary hypertension, or it may be pulmonary hypertension secondary to reversal of shunt, Eisenmenger syndrome, and class 3 and 4 where there are repeated failures, severe obstructive cardiac lesions like severe mitral stenosis or aortic stenosis, where the Marfan syndrome with the root dilatation greater than 40, severe cyanosis, and peripartum cardiomyopathy in the previous pregnancy is probably a relative contraindication, and we have to reassess the woman during the preconceptional period in the interval period and find out whether the cardiac function has returned to normal. Then only we can plan pregnancy. So medical termination is indicated in primary pulmonary hypertension, Eisenmenger, coarctation, Marfan's. In what are all the conditions it is contraindicated, better to go for a medical termination of pregnancy at the first trimester, and medical abortion is safe, and we can go for suction evacuation also, and MTP also carries a slight risk. So contraception can be barrier contraception, or it can be a progesterone only pill, mini pill, or Norplant. I wouldn't advise much of DMPA. Norplant, progesterone only pill, barrier contraceptions are ideal, and IUCDs are very safe. There is no contraindication, and combined oral contraceptive pills are of course contraindicated. And if needed, the patient has completed the family, we can preferably go for either a male vasectomy or a female sterilization. So this is an approach to contraception and cardiac thing. Like IUCDs are not contraindicated, implants are not contraindicated, DMPA can be used with caution, POP is quite safe, and CH combined hormonal contraception is not good. So in congenital heart disease, we have to have what is the type of congenital heart disease the patient has got. The acyanotic heart disease patient can undergo smooth antenatal period, and it has got certain impact upon the minimal impact upon the obstetric and the fetal outcome. So coming to the valvular heart disease, there are definite hemodynamic changes, and the stenotic lesions are very dangerous, especially the mitral valve and the aortic valve stenosis. The patient, they do not tolerate. But on the other hand, regurgitation lesions are not that much bad in pregnancy. So the patient can be allowed to continue the pregnancy with moderate regurgitant lesion also. Severe regurgitation lesions with the failure, that is not a pregnancy is not safe. Again, prosthetic valves, they are now coming up in a big way because we see a lot of patients with a post prosthetic valve pregnancy. The valve can be either a bioprosthetic valve or it can be a mechanical valve. Again, one important thing I wanted to tell you is, what about the dose of warfarin? Generally, we say oral anticoagulants when the patient is conceived. Immediately, we should switch over to the heparin during the first trimester. But now the recent concept is, if the dosage of warfarin is less than 5 milligram, probably the patient can continue, and with the minimal dose of warfarin, if they can maintain the INR of twice the normal amount, patient can safely go through the pregnancy. Otherwise, it is always better to change over either to unfractionated heparin or a low molecular weight heparin. Then again, during the mid-trimester, the patient can be switched over to the oral anticoagulant, and at the term, nearing term at 36 weeks onwards, before the patient gets into labor, better to convert it to heparin. So pregnancy in prosthetic valve is preconceptional counseling, pre-pregnancy evaluation, change to heparin from oral anticoagulants. That is based upon the requirement of the oral anticoagulant. Higher the dose, we can convert, otherwise there is no need, because with the higher dose of anticoagulant, the baby is likely to have certain increased incidence of congenital anomalies. Proper AN care, monitoring, change to oral anticoagulant in the mid-trimester, then delivery, admit and change to heparin, and preferably a delivery should be in the tertiary care. And bioprosthetic valve patient, they don't need any anticoagulation. So then I will just management of women with ischemic heart disease. It's quite nowadays with the ART techniques where the woman achieve pregnancy at a later stage, 45 years and above, and because of the obesity, hypertensive disorders, and diabetic reasons, these women have to be evaluated prior to pregnancy, prior to taking in for ART. And if they conceive, they need a teamwork of the cardiologist or the obstetrician, and they have to be evaluated thoroughly, and prophylactic aspirin can be given for them. And in IHD patient, if they need, they can be put on vasodilators. And even I heard clopidogrel is not a contraindication during pregnancy. Then heart failure is another important reason, and all the cardiomyopathies, congenital heart disease, arrhythmias, ischemic heart disease, pulmonary hypertension, and valvular lesions can cause cardiac failure in pregnancy. And this cardiac failure, again, the patient, it depends upon what is the ejection fraction, and preferably the maternal mortality is going to be high in patients with cardiac failure, and the long-term complications are going to be high. And the lesions, the indicators for poor pregnancies, when the patient has got a multiple cardiac comorbidities and a black race and an elderly age group, they have a higher problem. They have increased risk of problem, and the patient has to be better hospitalized, and they have to be given proper anti-failure measurements for digoxin and then diuretics, and always they have to be followed up with the periodic blood investigations, BNP, ECGs, echocardiography, and she should be under the constant care of cardiologist. And again, during the antepartum period, better they can be put on hydralazine, beta blockers, diuretics, hospitalization if delivery, and consider the mode of delivery is preferably a vaginal if it is going to be an easy one. Otherwise, explaining the risk, we can go for a C-section. In the postpartum period, again, the patient can be converted into antihypertensive instead of this hydralazine. We can convert them once again back to ACE and ARB inhibitors, and then diuretics can be considered, and then definitely management should be planned. So peripartum cardiomyopathy itself is a different talk, but it usually occurs in the last 1 month and the early 5 months during the postpartum period, and undue fatigability, undue tachycardia, paroxysmal nocturnal dyspnea, and orthopnea are all the signs. And if it has got variable reasons, it is common in multipara and multiple pregnancy. In pregnancy-induced hypertensive disorders, it is very common. Viral etiology, and in the previous history of peripartum cardiomyopathy or a viral myocarditis is a high should highly suspect future peripartum cardiomyopathy, and they have to be either ideal thing is they should be monitored prior and planned pre-pregnancy counseling is a must, and only when their injection fraction is good or beyond 45% they can be allowed to become pregnant. Otherwise, the maternal death rate is going to be high, and they have to be observed very carefully during pregnancy. So again, pregnancy with cardiac pacemaker is also coming up because we see quite a lot of these women with a pacemaker. You have to, in fact, there is no problem in antenatal mothers who have a cardiac pacemaker. Arrhythmias, anti-arrhythmia drugs, and anticoagulation can be done because all these arrhythmias can be controlled by the cardiac pacemaker. And if at all it happens, acute management has to be done in between, and then consider ablation for refractory cases. So, or in general, pregnancy with cardiac pacemaker is a very safe one. And postpartum follow-up is about contraception, which we have already discussed. Postpartum monitoring is must, and then plan for the definitive treatment, and future cardiac risk factors are very high. Any patient with the adverse pregnancy outcome, adverse effects of APO, that is adverse pregnancy outcome, during the antenatal period, they are at a high risk of developing future cardiac ailments and future cerebrovascular disease, and all those things have to be explained. And this is a chart showing that what is the risk. So GDM, gestational hypertension, preeclampsia, preterm birth, and small for gestational age. All these things are going to cause long-term cardiovascular risk. So it needs a teamwork, cardiodiabetology, cardiac obstetric team, pre-pregnancy counseling, monitoring during pregnancy, delivery planning, and postpartum, and it should be a teamwork. So pregnancy, heart disease, and labor, my final message is save the heart from pregnancy, save the pregnancy from heart, and save ourselves. And finally, thank you so much. And finally, I'm contesting for the post of Vice Chair elect of ICOG. I need all the blessings of the and support of the ICOG fellows. Thank you for the opportunity given.
Priya is not there.
Yeah, Priya, I think we don't have chairpersons for this talks.
Yeah, madam. Priya is the coordinator.
Priya?
Anyway.
Hi, Chitra.
Ma'am, it was very nice talk, ma'am. You are
Thank
really elaborated. I think only I have listened to madam on endometriosis and obstetrics, but this is something different. Very nicely presented, ma'am. It was very good.
Thank you. Thank you.
As though listening from a cardiologist, it seems like.
Yeah, so much up to date, madam was told.
Instead
So
of
good.
Madam Sir is sitting there and talking. Okay.
Yeah.
Can we go on to the next topic, madam?
Ma'am, I think, ma'am, Shantima, you can start it off.
Yeah, Shanti, you
think so. Our Dr. Priya is on
not there. Yeah.
Hypertensive disorders in pregnancy, ma'am.
Yeah. It's seen?
Yes, ma'am.
Slide seen. Not moving. The slides are not moving. How to do
Yeah,
that?
that's what it's not moving.
You touch the slide,
Ma'am, please double click on the slides, ma'am.
Click on the slide. Yeah.
Okay. Okay. So can I go back again? It's difficult. Yeah. Thank you. Thank you, AMOGS Emergency Obstetrics Committee for the opportunity, and thank you, Snega ma'am and Ramani ma'am for this opportunity. My topic today is hypertensive crisis. A very good evening from Teni. This is the pregnant place I am living in. And hypertensive disorder in pregnancy affects nearly 10% of pregnancy globally and are responsible for 26% of the maternal death. So it is a significant and unresolved problem in obstetrics. Why this 26% maternal death we cannot able to prevent in spite of our extensive obstetric care is that the disease has an ambiguous presentation. That is The patient may present with an abruptio with a BP of 90-60, and 1 or 2 days after that, suddenly she threw a fit and went in for AKI. So this is the patient already hidden hypertensive disorder pregnancy is the underlying cause. That is, some of the patients can present with a normal BP and throwing fit. So the disease itself have ambiguous presentation and it has an unpredictable progression. The day before, the patient maybe have a normal blood pressure, and the very next day she may throw a fit. And we also have a sad story of our losing our physician in the recent times. So it is an unpredictable progression. This is the maternal death statistics over the years in TNE, where this blue part chunk is shown as a death due to preeclampsia, and 2023 successfully we have overcome the death due to preeclampsia. This is due to the strenuous effort put by the obstetrician and also entire district. All the PHC doctors and paramedicals, they are trained with the various protocols and programs. So hypertensive crisis, it is an acute obstetric emergency. It is categorized as hypertensive urgency and hypertensive emergency. Urgency means systolic blood pressure is more than 180, diastolic is 120, with the presence of significant symptoms. The patient may have a headache, dyspnea, but there is no acute end organ damage. Whereas hypertensive emergency, it's an elevated blood pressure accompanied by progressive end organ damage. Also, when the end organ damage is accompanied, it is considered as hypertensive emergency. So a hypertensive crisis requires prompt detection, evaluation, and treatment to prevent. Our aim is to prevent the irreversible or permanent end organ damage. So the that happened is already happened. We want to prevent the further damage or a permanent end organ damage we want to prevent. So ACOG describes hypertensive emergency in pregnancy as persistent. That is, it's lasting for 15 minutes. Usually we want to check the BP after 4 hours. In a case of high BP, we can have an interval of only 15 minutes. So it is an acute in onset, severe hypertension, systolic more than 160, diastolic more than 110 in the setting of preeclampsia or eclampsia. So now when the BP elevation persists for 15 minutes, that is 160, 110, we begin the treatment as early as possible. If the too severe blood pressure are obtained within 15 minutes, that is, it may not be consecutive, or it would be 160 or 110. After that, after 5 minutes, it may be 150, 100. Or the next BP shoot up again within 15 minutes, that also considered as an hypertensive emergency, and the treatment should be started. So this is the various organ involvement a hypertensive emergency can present, and most of the things are managed medically by the physician, but preeclampsia and eclampsia is entirely in obstetrician hands. The SAFE committee, mother committee, put forth this hypertensive bundle approach. So this is risk assessment and prevention. It has a diagnostic criteria and when to treat and what are the agents to use and monitoring and complications. So look for complication, further evaluation, and you should go for a postpartum surveillance. So it starts with the assessment. You should take a complete history and physical examination regarding the various organ involvement, whether the CNS, pulmonary, lung, or liver, the coagulation system, or renal, and also the placenta insufficiency can present as an IUGR. So a complete history and physical examination is the mandatory first step in a case of managing a hypertensive crisis. And documentation. Documentations of the baseline babies throughout the pregnancy, and what are all the drugs she had taken throughout the pregnancy, and current vital signs, and what are all the antihypertensive taken already, the dose, the route, and also whether she had been given a Maxel prior to that referral. And all the baseline laboratory investigations you have to see to know the organ involvement, the platelet count, peripheral smear, and LFT, RFT, and LDH, uric acid prognostic value, and coagulation profile, and urine for protein or spot PCR, fundus examination, and then a basic ultrasound for maternal organs and also fetal well-being. So the management primarily consists of 3 components: antihypertensive, anticonvulsants, and termination of the pregnancy along with the supportive treatment. The antihypertensive of choice is here only a parenteral. It is either a intravenous labetalol, intravenous hydralazine. Where the IV access is not possible, you can go for an oral lefidopine. The BP should be reduced promptly but slowly. So this is the labetalol, what we are using widely, and we have a good experience with that drug. So when the BP is 160, 110 and it persists for 15 minutes or more, or as we talk, 2 severe elevations within 15 minutes, you should initiate the treatment. Initial treatment is labetalol 20 milligram IV for a period of 2 minutes and repeat the blood pressure within 10 minutes. If still it is 160, 110, you can go for 40 and again repeat within 10 minutes, 80 and again 10 minutes, 80 milligram. Then if it is not responding to the whole of the dose, you can start a labetalol infusion too. So the infusion is started with a 2 milligram per minute, or it can be given as a 20 milligram per hour, and after that 40 milligram the next hour. It can be titrated according to the fall in the BP. So in the patient BP is still 160, 110, you have to have an emergency consultation with all the internal medicine, anesthesiology and critical care. The maximum dose 300 milligram is not to be exceeded. It is especially contraindicated in the case of bradycardia. And hydralazine is another drug available. In our place, we are not using this drug quite often. So hydralazine 5 milligram and repeat BP in 20 minutes. You can repeat for 3 times. Then if the BP is not coming down, either you have to start an hydralazine infusion or you have to get the consultation from the expert team. And when the IV access is not possible, you can go for a nifedipine oral. So immediate release tablet is 10 milligram, repeat the BP and 3 times you can repeat the nifedipine. And it's not BP is coming down. By the time you should refer the patient for a parenteral antihypertensive, or you can very well start the IV labetalol by yourself. Starting the labetalol, even in the primary health center, we have tuned up all the primary health center doctors to start an antihypertensive parenteral. So if IV is not accessible, you go for an oral nifedipine, and in an emergency, you can even go for an oral labetalol 200 milligram. When no other sources is available, you can go for an oral labetalol, and you can repeat it after 30 minutes till you can refer. In the institution, when you are not able to control with these parenteral drugs, then you can go for an sodium nitroprusside or anti-G drip in and only with the anesthesia team and critical care and emergency medicine. And magnesium sulfate is the cornerstone. We all know how to use, and it's a Pritchard's regime and Suspend regime. And the Suspend regime is only IV loading dose followed by that of the IV maintenance dose. What we are widely using is only Pritchard's regime. And monitoring, once BP is controlled, and the BP should be monitored every 10 minutes for an hour and 15 minutes for the next hour and every 30 minutes for the next hour. And every hour along with the fetal monitoring. So that the timing of the delivery. You want to terminate the pregnancy because it is a hypertensive crisis. Once the patient is stabilized,
please mute Madam Anjalakshi.
It's from my side.
Madam Anjalakshi.
The audio disturbance is from my side or?
No, Dr. Anjalakshi. Saiti, can you please mute Madam or make me a co-host?
Okay, thank you. The timing of the delivery. So you should, prior to terminate, think about the termination of the pregnancy, the patient should be stabilized. That is the most important thing. When the patient is having high BP 170, 120, 110, you should not be in a panic to terminate the pregnancy. The patient should be stabilized. You should have a laboratory investigations, and by the time whatever you want to supportive treatment you want to give, all the treatment you should give after stabilizing the patient only. You should think about the termination of the pregnancy. If it is more than 34 weeks, we can very well terminate the pregnancy at the time itself. We can decide. And if it is less than 34 weeks, even in a case of uncontrolled hypertension, in the presence of pulmonary edema or abruption, eclampsia, or the fetal condition is not good, you want to terminate the pregnancy. In the help, if it is less than 34 weeks, you should overweigh the risk versus benefit. If the maternal and fetal condition is stable, you can give antenatal steroid and deliver. In an hypertensive urgency, where the patient is asymptomatic, only with the BP is there and there is no end organ damage, and the BP is well controlled with an antihypertensive therapy, you can give an antenatal steroids and we can have an expected management, but with the careful monitoring of the patient. Anytime she may go for an emergency. And mode of delivery need not be a cesarean section. It depends upon the urgency to deliver, and also depends on the Bishop's score, gestational age, and severity of the FGR and Doppler study. Now, it need not be always a cesarean. If it is in the cervical score is very favorable, you can go for an induction and the acceleration of the labor. The intrapartum management should be done in a well-equipped birthing center with an obstetrical expertise and all the critical care unit with the blood bank, anesthesiologist and neonatologist. And intrapartum monitoring, continuous CTG monitoring is the mandatory thing. And coming to postpartum surveillance, measure BP every 4 hours after delivery until stable. Antihypertensive treatment should be continued. Do not use NSAIDs for a woman with an elevated BP. Do not discharge the patient until BP is well controlled for at least 44 hours. And all patients receive information on preeclampsia, signs and symptoms, importance of reporting information to the healthcare provider as soon as possible. So the patient should be taught in a culturally competent and patient-friendly language that she should approach to the healthcare provider whenever she is having a problem. And she should also instructed to adhere to the antihypertensive. So post-discharge evaluation. After discharging the patient, the outpatient surveillance is the most important thing. It should be done within 3 to 5 days. Again, 1 week after delivery. The signs and symptoms of eclampsia and abnormal neurological evaluation, renal failure, coagulopathy, everything should be communicated to the person who is going to visit to her. And this is an obstetric bundle development, as we talked previously. This obstetric bundle development is used to delineation of the standard of care and minimization of the variability, decreased reliance on memory, and emphasize patient safety and reduction in redundant efforts. This consists of an PowerPoint, visual aids, checklist, algorithms, risk assessment tables, medication dosing tables, and debriefing forms. These are all the, we have many success story, but I want to project 1 or 2 failed stories where we lost the patient. I want to impress what are all the things missed in this case. That it's like an audit only. She is a second gravida with the previous normal delivery. She visited a primary health center for her checkup, and her blood pressure was 120/80. At home, she developed seizures and brought to GH where BP was 180/130 and maximum loading dose was given, and patient was referred to tertiary center. And patient was drowsy, intubated and managed with the antihypertensive. Emergency LSC is done, but patient developed hypoxic encephalopathy, modes and died. So where we want to insist, the thing is that the patient should, you should not think that Maxelf is the antihypertensive and it will control the BP. She should be given an antihypertensive, and parenteral antihypertensive is the choice before the referral. Never hesitate to give parenteral labetalol in a primary health center or in a private sector, wherever you are, when the BP is 180/130. Yes, mere giving the parenteral antihypertensive would have saved this patient life. And also regarding the BP was recorded as 120/80 and 180/130 within 12 hours interval. So the way you take the blood pressure is more important. These are all smaller things neglected, end up with a loss of one life. And this is another case. She's para-1 live one, gestational hypertension on antihypertensive drug, discharged following a normal vaginal delivery, and patient was readmitted and brought in a moribund state, could not be revived. Here the patient didn't continue this antihypertensive, and she had not been given proper discharge instruction, and the patient was not followed up in the post-natal period by a local village health nurse or whoever the healthcare provider had not visited her. So the patient is not aware of continuing the drug, the necessity of continuing the drug, so end up with eclampsia, and she was brought in a later stage. So this is the third case scenario. She termed gestation, she went for giddiness and her blood pressure was 150/100. She was given IV fluids and referred to tertiary care center. So on admission, patient was dyspneic, tachypneic, and there was a fall in the SpO2, and she was intubated, resuscitated, and postoperatively patient died due to refractory pulmonary edema. What I want to emphasize in this that fluid management in a case of hypertensive crisis or in a case of eclampsia. So the fluid management is more important even in the antepartum period as well as intrapartum, and more importantly in the postpartum period. Should not give randomly IV fluids for simple giddiness, and which ended up the patient life. So you should have this is given by the bundle approach. You should have a definitive protocols and checklist where you should display everything. The protocols, you should have an institution protocol or NHM protocols that is followed in our institutions, and you should have a checklist easy to make your job, and also for the staff nurses. And always there is a team should be there. Not only you and your team should have what should be done for a patient with the emergency hypertensive crisis, and there should be always an audit like this, what we have missed, what we can rectify, and documentation is more important. The ultimately have to save the patient and save ourselves. And this is the last slide I usually want to project. That is, this is I have stars whether this sunrise or sunset. You can't say this is a sunset or sunrise until you see the whole picture. This is the sunset, because you should not see the patient only the BP. That is only the iceberg of this entire condition. There's a lot of pathology going down entire body when there is a blood pressure is only a tip of an iceberg. So you see the patient as a whole, and a holistic approach to the patient will save most of the patient life in an emergency, especially in a hypertensive crisis. So this is stop PH mortality is that goal of this Tamil Nadu NHM, and hope we should all work together and make there is nil mortality to the PAH, hypertensive disorder. Thank you for the opportunity.
Thank you, madam. That was such elaborate explanations. Very beautifully explained, madam. It was mind blowing, and a very beautiful sunrise or sunset. Your insight. It was very lovely. So, Dr. Sneha, madam, you wanted to say something?
Yes, of course, Shantirani. It's a very, very important message what you have given. Blood pressure is not the predictor, not the only predictor of severity. In fact, you have so many other parameters, the alarming symptoms, signs, and the laboratory parameters. So one should not look at only blood pressure. She may have received antihypertensives. And of course, hypertensive crisis, that you have to recognize, and I will be having the panel discussion also now, so I'll clarify it definitely. You have discussed very, very important aspect of the hypertensive crisis, and of course all the aspects of hypertensive disorders of pregnancy. I would say the initiative, as you said, all of us should come together, because when you can predict, you can to some extent prevent the complications. In spite of this, and when you have so much of educational initiatives for management of preparedness of managing eclampsia, why should we lose our women to this deadly disease? So that is what still a question which is still unanswered. So all of us should come together and work for this cause. That is what I believe. So thank you, Dr. Shantirani. And if anybody has any comments, I think I can see Madam Ramani Devi and even PK Shah sir, if at all sir has any comments, definitely they are welcome. Sir, please unmute yourself, sir. Please unmute, sir.
Yeah. Excellently covered topics, and I'm thoroughly pleased the way Dr. Ramani Devi took cardiac disease in pregnancy. I'm reminded of our teachers from KEM Hospital. And she is an extraordinary teacher And it's something great to hear from Madam again and again. Thank you very much, ma'am. And the same thing for hypertensive crisis. I think it was covered beautifully. Thank you.
So Priya, can we move ahead with the panel discussion now,
Yes, ma'am. Yes.
please?
Okay, thank you. It is my pleasure to invite our Neha madam as a moderator. I will not be going with the madam slides. Can we have the slides of the panelists?
I have been introduced already. You can go ahead.
Yes,
Short
ma'am.
introduction of the panel.
So Dr. Jayamala madam, madam is a consultant obstetrician, gynecologist, fertility, and a laparoscopic surgeon, and as well an assistant managing director, Rainbow Hospital, Salem, president of the OG Society of Salem. And madam, we all know that madam has been worked in a public, Republic of Ireland from 2000 to 2009, and she's, come back to India from 2010, and she's been the consultant in SKS Hospital and the Rainbow Hospital, Salem. Can we have the next CV, please?
Welcome, Dr. Jaymal.
Dr. Bharti Rajashekar, madam. Dr. Bharti, madam, are you there, madam? Madam,
No.
madam is a.
I don't see her.
Yes, madam. Madam has been the president of the Kasoga.
Priya, just tell one or two sentences enough for Priya.
Yes, madam.
Because we are running short of time.
Sure, madam. So, madam is the president of Kasoga, and once madam is there, I think we'll call her again. Thank you. We'll go to the next CV, please. Dr. Anita Rajoria, madam. Madam is the head of the department and senior consultant from Delhi, and madam has also been there as a founder, vice president, Delhi chapter, and the adolescent committee chairperson 2021-23, and the past chairperson for reproductive endocrinology committee and the executive committee member of the AOFOG. So welcome to you, madam. So Dr. Chandrakala Maran, madam. Madam is the head of the Department of Obs and Gyn and the faculty of DNB program in the KG Hospital, as well as madam has been the organizer for the National Conference 2010 from Foxy, presented various papers, posters, and so also awarded the Best Paper Award and published many papers. Welcome to you, madam, Dr. Chandrakala, madam. Madam Dr. Sujata Alagason, madam. Madam is a professor of Obs and Gyn, Tirunelveli Medical College, Foxy Tirunelveli branch, as secretary for the past 5 years, conducted live workshops, Oxy conferences, Yuva Foxy, and national faculty, and presented many papers and posters. Welcome to you, madam. Dr. Rashmi, madam. Madam is a senior assistant professor in Kanyakumari Medical College, as well as the secretary of the Nagarkoil Obs and Gyn Society. Welcome to you, madam. So Dr. Chitra, madam. Madam is a professor from JIPMER, and she's been a fellow in reproductive medicine, and as well as many of the certificate courses, awarded papers, and she's been always with us for the quiz committee. Thank you, ma'am.
Thank you.
Presently. Dr. Kavita Abraham, madam. Madam is a professor of CMC Vellore, as well as madam is a member of the Vellore Obs and Gyn Society, member of Foxy, being the teaching faculty for more than 10 years with special areas of interest in IRFs obstetrics. Welcome to you, madam. So, Dr. Renju, madam. Madam is assistant professor of Erode Medical College, a PG from Thrissur, and a faculty in the National State Conferences, and she's a joint secretary, Erode Obs and Gyn Society. Welcome to you, madam.
Welcome, Dr. Anju.
So over to you, Dr. Sneha.
A very good evening to all of you, and I welcome all dear panelists. Without much ado, I think we should go ahead with the panel discussion. So Dr. Jayamala, Dr. Chandrakala, Dr. Sujata, Dr. Reshmi, Dr. Chitra, Dr. Kavita, Dr. Renju, Dr. Bharti, I didn't see, and Dr. Anita Rajoria. So all of you, I welcome once again. Can you just let me know who, other than Dr. Bharti Rajsekar, who is not here?
I think all others are there, madam.
Yeah, okay. So that is very good. So friends, all of you know that why are we worried so much about, you have just heard the talk of Dr. Shanti Rani, and of course she has discussed the subject very well, the management of hypertensive crisis. So why are we worried so much, and what is this hypertensive crisis? All of you know this. Just to revise, I would just start with saying that systolic blood pressure of more than 160 and diastolic blood pressure of more than 110, we label this as hypertensive crisis. And this we have to divide into emergency and urgency for the management purpose. So why are we worried so much about this blood level of blood pressure? Because our system, our vasculature is not adapted to all this kind of very high blood pressure, and that is why we are likely to face all these complications like CNS, especially the eclampsia and other CNS complications, intracranial cerebrovascular accidents, acute respiratory failure, HELP syndrome, hepatic complications, abruptio and other uteroplacental complications, CVS complications, acute kidney injury, and hematological complications. So, friends, can we mute those who are only participating? I think Sahiti, please take it. Sahiti, yeah. Hello, Sahiti, please make me co-host otherwise. So I think Dr. Shantirani has already covered the theoretical aspect. So without much ado, we go ahead with the case scenarios. So we start with Dr. Jaimala. Dr. Jaimala, yeah, good evening. And let us discuss this first case. We have this 36-year-old lady who conceived after IUI. Her husband is working in Dubai and she stays in a village, but because it's a precious pregnancy, she comes to the doctor for routine antenatal care. And at around 28 weeks, the obstetrician informs her things are fine, everything is normal. So she is lost to follow. Suddenly at 34 weeks, she reports to one PHC with epigastric pain and pedal edema. And there at PHC, the blood pressure is 178 by 116. What is your diagnosis at this point of time? And what are the investigations you would like to go ahead? How will you manage this case?
Yes, ma'am. She's a primary, suppose, and yeah, 34 non-compliant patient, obviously, because she was lost for follow-up. Okay. And yeah, with 34 weeks, she came with epigastric pain, pedal edema, and BP of 170 over 116. It is like preeclampsia with severe features.
Yeah.
So that is her diagnosis.
So how would you go ahead with the management?
Yeah, of course. First of all, she needs to be admitted, and then you start her, put an IV line, check her ABC, put her IV line, take bloods for preeclampsia screening. Sorry, preeclampsia bloods like CBC, uric acid, LFTs, urea creatinine, urine protein, and urine protein by creatinine ratio, and all these things. You take PTINR, take the bloods for these and send it. Then start her on, and repeat the BP and start her on IV labetalol alpha.
In addition to the laboratory investigation, the blood hematological investigations, any other investigations you want to do for this patient, especially 178 by 116?
You mean acute investigations?
See, I have already said that maternal evaluation, because she is a case of severe hypertension. So she is likely to land up into all this. So what other investigations you want to do for this patient?
This would be my immediate investigations. First, I would like to control her blood pressure and then do the other investigations.
Right, right.
As I said, like she's if she hasn't done an echo before, like check whether she had an echo in her first trimester. If not yet, you can do her echo. Then, if you have an on-site, physician, immediately you can call for a fundoscopy. Yes, I am not trained in doing fundoscopy, so usually I get him. So
we are not supposed to do it also. We are not supposed to do it. We have a specialist, ophthalmologist. Definitely would be the best person to do this. Okay. Exactly. So how would you manage this patient? Investigations, right? You started the management naturally with investigations. Immediately you would. But what drug you would like to start her? And how would you decide whether to take this pregnancy ahead or you would want to terminate this pregnancy? How do you decide that?
I would, first of all, try to control her blood pressure, start her on IV labetalol, 20 milligram IV, then wait and recheck her BP after 15 minutes. Okay, sometimes they come in initially, it is like that if your urine protein is just 1+, and if it comes down, you can do a scan, check for the baby's weight, look for if there's any IUGF features, look at the Dopplers, if the Dopplers are fine, and if the baby is not an IUGF baby, if the blood pressure comes down and all her blood parameters are normal, you can give her steroids, wait for the steroids to act, and you can put her on max self to prevent,
So I interrupt you here little because we want to give some message. So we are talking about the management of hypertensive crisis. So you have very well said that you will give her antihypertensive, but you will look for all these things. So what is it that decides the management of these hypertensive crises?
Okay. If the blood pressure is not settling, if there are no urine protein,
no, in addition to blood pressure, in addition to, she is a case of severe hypertension. You know that she is into severe, hypertensive crisis. What is it that decides the way of management?
Okay. As I said, uncontrolled hypertension first. The other thing is blood parameters. If there's any associated health
So what do you check? Exactly, I'm giving you the hint that what do you check by doing the blood parameters? It's the presence or absence of the end organ damage.
Okay.
Creatinine? Yes. So if you have end organ damage in addition to severe hypertension, you label this as hypertensive emergency.
Exactly.
Emergency, end organ damage. If there is no signs of end organ damage, then you label this as urgency. Now tell me what is the difference between the two and how this differentiation helps us in the management of this patient.
Okay, as I already mentioned, like if the BP settles and all the other parameters are normal, if you're going to continue the pregnancy, it comes in the urgency. If it is uncontrolled and if the blood parameters are abnormal, if there's any associated HELLP syndrome, and if you're going to terminate the pregnancy, then it comes into emergency.
Emergency, perfect. Yeah. So even while controlling the blood pressure, if it is emergency, you have to control the blood pressure as soon as possible. Whereas if it is only urgency, there is no end organ damage, you still have around 12 to 24 hours where you can gradually bring down the blood pressure, right? So for emergency, you have to go ahead with the intravenous route of antihypertensive, especially the labetalol and maybe hydralazine. But if at all you have urgency, then maybe if you are well versed with nifedipine, capsule nifedipine, and if you are not so well versed with IV labetalol, or you don't have the facilities for microinfusion pump and the monitoring, maybe you can go ahead with the capsule nifedipine, right? Okay.
Yes.
So you now these investigations we have already talked about. Now for this patient, what is your plan of management? One is, of course, you have to control her blood pressure. And you have to differentiate whether she's a case of hypertensive emergency or urgency. And then, of course, you have to see to it that she doesn't convulse under your treatment. So what is your management for that? Whether you would like to give prophylactic magnesium sulfate, what is the dosage and schedule, which regime do you follow, and what are all the regimes? These are all the questions for you.
Good evening, ma'am. I'm Dr. Chandrakala.
Yeah.
Yes, madam. Madam, from what we understand, this patient is 34 weeks pregnant and she's got severe features. She's come actually is preeclampsia with severe features. She's also had complaint of epigastric pain, which might she's got one of the imminent symptoms of eclampsia also. So the ideal thing is to control the hypertension and plan for a delivery. But in between, of course, we'll have to take other precautions. And as the previous madam has told, the preliminary investigation shows that the fetal growth is normal and then there's no end organ damage. So we have got some time and then so we can plan for her delivery. In the meantime, we give her magnesium sulfate. In general, we follow the Pritchard's regimen, which is either IV or IM regimen. If the patient is throwing a fit, she's a case of eclampsia, then we give IV 4 grams and then we go 1 gram per hour, IV every hour.
That is Zuspann's regimen.
Yeah, that is Zuspann's regimen for 4 grams and 1 gram.
So what is Pritchard's regimen?
Yeah, in Pritchard's regimen is if the patient is throwing a fit, it is 4 ml, 4 grams IV and 5 grams in each buttock immediately has to be given. That is total 14 grams initially and then 5 grams alternate day, on alternate gluteal regions once in 4 hours. And in between, we do monitor for toxicity of magnesium before
What are
giving
the parameters you would like to look for?
We generally check for the urine output, which has to be at least about 25 ml per hour. And then we'll have to check for the knee reflexes, the respiratory rate, which has to be at least 16 per minute. And we'll also, at times, if the patient has got an end-organ damage, where the creatinine is more than 1, then we'll also have to check the serum magnesium levels and maintain it within 4 to 7 milliequivalents per liter.
Okay. So now, once again, I interrupt you here that I had asked you whether should we go ahead with the prophylactic magnesium sulfate. But then you said that if she throws a convulsion, that means it becomes a therapeutic, right?
Therapeutic.
So
Yes,
we are talking about the prophylactic magnesium sulfate.
As it is
What is the role of prophylactic magnesium sulfate and what is the dosage schedule? Is it different from this therapeutic?
Yeah. In actually, the MAGPIE trial says that the prophylactic regimen prevents in case of imminent eclampsia, prevents an eclampsia.
Right.
In that case, we will not
that is what we want to clarify, that it is prophylactic means only it prevents the convulsions. It prevents eclampsia. Prophylactic doesn't mean change in the dosage or the regime, right?
Yes,
madam. So the dosage and the regime remains the same, right?
Yes, madam. It's only the intramuscular regimen which we would be following.
Right. Now, should we give magnesium sulfate to this patient? That is what is asked. You have already said that fetal growth is normal. There is no evidence of any end organ damage. So if your patient has transient severe hypertension, that is urgency, if you can manage her only with the antihypertensive and you can stabilize her, if she is only 26, 28 weeks, you want to take this pregnancy ahead. So should we give Maxal or no?
Yeah, the magnesium sulfate, the role of magnesium sulfate are two. One is like if she was at 26 to 28 weeks, we would give her neuroprotection as well. And give neuroprotection as well. But now she is 34 weeks of pregnancy. So here it would give the benefit of preventing an eclampsia. And we will buy some time and we can have some time to give steroids.
Yeah, even if it is 34 weeks, it is recommended right up to 34 weeks, 6 days. Okay, so definitely there is a role of magnesium sulfate for neuroprotection. Yeah, so Dr. Sujata, I'm giving you these questions. Basically, this patient, how she is managed or mismanaged, all of you decide. So she was not given IV labetalol. She was given tablet labetalol 100 mg, 1 tablet twice a day. Tablet nifedipine retard, 1 tablet twice a day, steroids and magnesium sulfate. And this patient got admitted at a higher center after 2 days. Okay. And this was not, of course, the obstetric SDU. This is wrongly printed here, but she got admitted to the sub-district hospital and she received all this wrong management. Okay. So in spite of all these drugs, the her blood pressure remained between 160 to 170 and 112. So should we label this as refractory hypertension? Dr. Sujata?
Yes, madam. So, am I audible, madam?
Yes, definitely.
So, first of all, this patient should have been admitted. She was not admitted. And then for this severe hypertension.
She was advised admission, but she did not get admitted. Yes.
So, the labetalol dose also could not be monitored. It is ideally an IV labetalol should be started.
Right.
Which was also not started. Suppose she was in a remote area.
Yeah, but now we have covered that. We just want to know from you whether it is refractory hypertension. Should we label this as refractory hypertension? Obviously, the answer will be no.
No.
Because she's not managed properly.
She was an unmonitored patient.
Yes.
So we cannot bring the term of refractory hypertension.
If she has received the optimum dosage of that appropriate drug, then in spite of that, if she is not, responding, then we label this as refractory.
Within 4 hours, if she is not getting control in spite of your all management,
maximum
then we can dosage.
Right.
So then you can bring it as a refractory.
Okay.
And then
now the actual actions, what you will do, what should have been done. And now you tell me that what should have been done for this patient.
One more point. Why retard was given?
Yes.
Because the patient presenting with acute hypertension, it is ideal to give the simple one.
Yes.
Because it will take quick action. It will have quick action. Retard takes some time to act.
Yes, that is what I'm saying. If you have severe hypertension, labetalol intravenous and nifedipine, not the retard tablet.
Yes,
It has to be that orange color capsule nifedipine 10 milligrams, right? Only thing is not in a hurry, never to be in a hurry. We don't want the blood pressure to suddenly come down, in fact. So never ever use it sublingually. Okay. It has to be capsule nifedipine orally. Now, what is the onset of action and the duration of action? Dr. Sujata, you can continue with this. For
We can give.
nifedipine.
So ideally, we have to start her on first line will be a labetalol IV, which begins, you give 20 milligram IV.
Yeah.
And it begins its action within 5 minutes. That is the first advantage of IV labetalol. Very quick acting. And so only we prefer that as a first line drug. And there's no palpitation or any drastic hypotension when compared with the other drugs. So that will be the first line drug. So you repeat check the BP every 10 or 15 minutes.
Yes.
And you can repeat the dose. So 20, you double the dose. You give another 40 milligram and then check. Then again you can give 80 milligram. So you can give up to 3 times 80 milligram. So 20, 40, 3 times 80. So around maximum, we can come up to 300 milligram. So still, if you are not getting control, you better switch over to either a labetalol IV infusion or you can go for the next drug. So you can switch over to hydrolyzine. So we have to be very strict monitoring. Every 5 minutes, you have to check the BP and you have to give the drug, and every 15 to 20 minutes, you have to repeat the dose and you have to settle the BP slowly. Suppose you are not, and you want to give an IV hydrolyzine, it takes little more time than labetalol. So 5 milligram you can give, and every 15 to 20 minutes you can increase the dose, and 20 milligram, and you can give the dose. You can repeat it. Suppose you are not happy with you're not having facility for a continuous BP monitoring or very close monitoring, you have only tablet you are available, then you can go for an immediate release tablet nifedipine. I think capsule nifedipine, it's we prefer only for a tablet nifedipine, immediate release tablet. We have sustained release also. So 10 or 20 milligram you can give, maximum dose up to 80 milligram. So every 20 to 30 minutes you can repeat the drug. So this is what we can give. Suppose still you are not getting control. Only the last resort will be the sodium nitroprusside, which is contraindicated, but only very rarely they say after
sodium
with all
nitroprusside,
hits.
right? And of course, the
It's
anti-G
contraindicated, yes. But without any, it's not getting control, some malignant hypertension
That
like
is what.
cases.
If it is only refractory hypertension, then only we should go ahead with sodium nitroprusside or anti-G infusion. These are very rare situations. If I tell you, in my 35 years of experience, I have used anti-G infusion for 2 patients till now. Of course, with the help of a physician. I have not managed on my own. Okay. So oral capsule nifedipine, we find all of us know that, the onset of action is within 5 to 10 minutes. The peak action is 30 minutes and the duration of action is 6 hours. So definitely the oral capsule nifedipine is a very, very effective and safe drug. Only thing is the precaution is not to give it sublingually. Okay. So Dr. Rashmi, do we have Dr. Rashmi here? Dr. Rashmi? Yes, I can see Dr. Rashmi. Please unmute yourself. Please unmute. Click on the mic icon. No? Ask to unmute.
Yes, madam.
Yeah, please. So, is there any role of MaxHealth? Actually, we have decided, we have discussed this, that neuroprotective and prophylaxis for eclampsia. So, this patient wanted her husband to come from Dubai. So, counseling was possible, fetal and maternal complications, whatever possible complications, we have done the counseling. And this patient was, continue to monitor. Now, she has received all these drugs, what we have discussed till now. So this patient received steroids also. She received magnesium sulfate also, and she received labetalol and nifedipine tablets. I've already told. So they had the facilities for anesthesia, so they took her up for cesarean section, and then consent for LSAs was taken, and a healthy female child, 1.8 kg, it was delivered. So during the cesarean section, what precautions we should take? Rather, I would say right from pre-operative, preload. Dr. Chitra.
Ma'am, since this patient, we need to have a two conditions which we should remember. Severe preeclampsia one, and there's high risk of undergoing a DIC and the high risk of patient having pulmonary edema. These two things and prematurity. One more, because you told 34 weeks of gestation. So we have to take on a white bore needle or send blood. At least keep 2 units of blood and fresh froze of plasma ready. And when anesthesia is given, try to avoid as much as possible general anesthesia. Regional anesthesia is the most safer, and to avoid pulmonary.
Sorry, Chitra, sorry to interrupt you. I would say just before operative procedure, pre-operative, any precaution, because which type of anesthesia you would prefer for this patient?
Madam, regional anesthesia is preferred because
right. For regional anesthesia, we do preload, right?
Yeah, but that should be not be too much, madam, because when you do
so that
preload,
is what the precaution we have to keep it in mind. That yes, preload, but it has to be very calculated and at a slower rate than usual.
Because that risk is and since I told prematurity is there, the lower segment would not be well formed, so your chances that angle extension can be there, have a difficulty in deliver the fetus can be there, so better to keep forceps or vacuum ready for the extraction. And since the risk of already severe preeclampsia, risk of PPH can also occur, so the measures should be taken, that adequate management of third stage of
management of third stage you want to use for this patient? What you said, we can land up into PPH.
Yeah,
what oxytocin you would prefer
20
for
units
this
of oxytocin can be given first, and second you can use prostaglandins preparations, and the one way now recently we started using
carbetocin.
No, madam,
not carbetocin.
Carbetocin we are not using at present. We are not using, either you use oxytocin and we use prostaglandins, and now tranexamic acid has been shown to be preventing PPH. So we are using the tranexamic, and since
so let me share with you that we have been using since last 3 years now. We are using carbetocin as a prophylactic drug for every patient, because it has got so many advantages that it is a single shot intravenous injection, single shot, no need for continuous infusion. And 1 dose of carbetocin is supposed to be equivalent to 16 hours of oxytocin infusion. That potent this drug is, but only it has to be used as prophylactic, because once you use oxytocin, then you cannot use the carbetocin doesn't become effective, because all the oxytocin receptors are utilized or they're depleted, because these belong to the same family.
True. Yeah, correct, ma'am.
So it has to be used as a prophylaxis before you use oxytocin, and that's why not as therapeutic. Once the patient starts bleeding, you have exhausted with all those drugs, carbetocin will not work. Okay, so good. So carbetocin.
Something, ma'am, can I add one thing?
Yes.
So epidural is, of course, the preferred.
Right.
Yes.
Definitely, because you have a sudden, you have the risk of sudden hypotension in these patients, and that's the reason we go for preload. But yes, spinal anesthesia is still regional anesthesia, I would say, still the preferred over the general anesthesia.
But most of the time, if severe preeclampsia, they land up as an emergency. So emergency is very difficult to give.
Patient is not nearby mouth and all.
What I was saying that during intubation, these patients will have sudden rise in blood pressure, so they can have stroke or other CVS. So anesthetist has to be a very skilled one and experienced one.
Right. So
I add something is there are studies which say the half-life of oxytocin is only half an hour, whereas the half-life of carbetocin is around 4 to 6 hours, 4 hours.
That is what I'm saying. One single shot, half-life of oxytocin is 5 minutes only.
Doesn't really make a difference.
Let me share with you, half-life of oxytocin is 5 minutes only. Because for Otris regime, we used to go for those studies, no? So it is shown that 1 hour, that is a cumulative effect, but half-life of oxytocin is only 5 minutes. And that is why single shot of carbetocin is supposed to be equivalent to 16 hours of oxytocin infusion. That is what I was sharing. Okay. So availability of the skilled neonatal care also, and then you have to monitor this patient in obstetric SDU.
Yeah, the more prone to have conversions, mostly postpartum if it's not controlled, ma'am. So
Right.
to be in HDU.
Okay. Any other precaution after the delivery of the baby?
So postpartum also intensive monitoring. The fluid overload is an important challenge. So
Right.
suppose she's having any fluid overload features, we have to see the IVC diameter,
Yes, so
CVP
what precaution
monitoring.
you will take, madam? What precaution? Try to
So
avoid methergine.
usually
Absolutely no to methergine, I would say,
Yeah.
unless the patient lands up into PPH. Absolutely no to methergine. Okay, that is one. And once you deliver the baby, because she's got edema, would you like to give her some diuretics?
No. Yeah.
Why no?
Why? We can give, madam, during anesthesia, yeah.
Yeah, when the
Vaccines
baby
can be
is
given.
inside.
That is, it is also prevents if at all preload as a card,
Right,
also prevents afterload and the risk of pulmonary edema. So after
Right.
baby, it can be
No.
given.
Because it's a loop diuretic, it pulls the blood from extravascular compartment into the intravascular, and then it leads to diuresis, right? So in fact, that will help in reducing even the generalized edema, and it will definitely prevent the pulmonary edema. So prophylactic diuresis, definitely. Okay. Once you deliver the baby, once the things are settled, you can definitely give her a shot of diuretics. Okay. Now, we go ahead with the management of this. So I told you that they delivered the patient with cesarean section, 1.9 kg. Female child is delivered. Cesarean section is uneventful. Now, why I told you, now you will understand. This patient's blood pressure, in spite of everything, remained between 160 to 170 systolic and 110 diastolic, because she was on oral antihypertensives, right? So after 24 hours post-seizure, this patient suddenly developed severe cough, breathlessness, restlessness, and pulse rate is 115, BP is 200 by 118, oxygen saturation goes down to 25%. What is your diagnosis now, Dr. Kavita? Dr. Kavita Abraham?
Yes, ma'am. Can you hear me, ma'am?
Yes, yes. Please go ahead.
Yeah. The diagnosis in this case, she's having tachycardia, and there is severe hypertension and drop in saturation with some wheezing also developing. So it would be suggestive of left heart failure secondary to severe hypertension.
Right.
And with the setting of pulmonary edema gradually evolving. So the management in this scenario, because the saturation is dropping, the first thing that I would prefer to do is start her on some oxygen, proper up, start her on oxygen, and we'll have to give it under positive pressure. And side by side, we'll have to start measures for pulmonary edema as well, like giving IV, furosemide can be given.
So I would ask you how much furosemide you will give.
Yeah, so usual dose is 1 milligram per kilogram body weight divided as boluses. IV boluses can start with 40 to 80 milligram as the first shot.
Right. Because why am I discussing this point? Because we obstetricians are very conservative. I have seen people talking 10 mg, 20 mg. So these are the pediatric dosages, and it doesn't work for pulmonary edema. So at least you said 40 to 80, but I would say 60 to 80 milligram of Lasix we would prefer to give, because at this point of time she is in pulmonary edema. So you have to, recover her from pulmonary edema first, naturally. So what else? Propped up position, oxygenation, positive pressure ventilation, and Lasix. Okay, what else?
And blood pressure is quite high, ma'am. So I would prefer to start her on IV antihypertensives. So the drug of choice would be labetalol.
Now I ask the other panelists, do we have a difference of opinion? Because for labetalol, if you remember, congestive heart failure, any heart that pattern, even the asthma, all these things, heart blocks, these are the contraindications. So for pulmonary edema, we have the drug of choice as nitroglycerin, NTG infusion. Okay, though it has been, we obstetricians are still using labetalol because we have that, and we are now much comfortable using IV labetalol. Okay, even I have mentioned it here, injection labetalol, but let me share with you that intensivist cardiology.
Nitroglycerin,
Yes.
NTG drip should be given ideally.
Yes. So NTG infusion should be given ideally, and of course for that you have to have your anesthetist or your cardiologist, by the side. Of course, such patient has to be managed in obstetric HDU or ICU. But if this happens in your post-operative ward, you have to manage it then and there only. And that is the very reason we have to know how to manage. And then, of course, once you stabilize this patient little, then you have to shift to the ICU. But see what has happened. This patient, she received furosemide only 20 milligram. Okay. And then this patient's saturation further dropped down to 55, then to 35. And, before shifting the patient to ICU, she, landed up into cardiorespiratory arrest. Now, Dr. Renju, we want to hear from you that how would you manage this patient now of cardiorespiratory arrest?
Cardiorespiratory arrest has manifested. Now her heart is not functioning. Her respiratory system is also not functioning. So she needs support for both a mechanical support and an inotropic support. For mechanical support, she will obviously have to be intubated because the anesthetist is there.
I would little interrupt you here. Sorry for that. If she lands up into cardiorespiratory arrest, would you like to give her some mechanical assessment, rather assistance before going? I mean, you have to shout for her basically, right? Because you need multiple hands to help you. So now you tell me, how do you start, whether you give her CPR and then somebody will give her IV drugs and water all day. Yeah, Dr. Renju.
Obviously, because this case has been there in the HDU for a long time, I am under the understanding that the anesthetist and the physicians, intensivist, everybody are around, and that is why I went for mechanical ventilation.
Yeah.
If at all, no problem. Monitoring
But
has been done.
What about CPR? CPR.
Yes, sir.
Yeah.
CPR, I will.
Talking about CPR, you have everybody in there, but how to give CPR, because we obstetricians should also know how to give, and what is the proper rhythm and how much pressure, how much it should be depressed. So we want to know the details from you. Yeah.
Okay, the left hand over the right hand, I'll place it straight over the sternum, 30:1 compression. But the first thing, because here there is left heart failure, I'll concentrate more on the C rather than breathing and airway. Airway, of course, I will see to it that there is no tongue fall. What I'll do is head lift, chin lift, and jaw thrust. That will be done the first. And the next thing is the 30:1 compression. It has to go 2/3 of the compression, 2/3 of the heart has to be suppressed, ma'am.
Right.
And then
5 centimeter, it should get depressed and elevated. 5 centimeter. Right. You're right.
And IV line is there because it is there. If the heart is completely failed, I'll give straight away an injection of adrenaline IM because the BP is now not recordable.
Right.
So I'll give an adrenaline straight away. Otherwise, I'll start an noradrenaline drip, ma'am.
Right.
And the oxygen support continuously has to be there. So with an ambu bag, I'll continuously try to give some or a positive pressure ventilation, whether it is a with the prongs or the ambu bag or whatever is available, I'll try to ventilate her lung also.
If she's not breathing, you have to intubate her, right? So it will be on mechanical ventilation only, right?
In the meanwhile, I'll try to tackle the pulmonary edema also. So maybe to reduce the left heart morphine if it is available, or else again, if the BP picks up again, I'll have to give her furosemide and try to reduce the workload.
Yeah. Yeah, so you are right. You have discussed it very well. I would just sum up and say that yes, this patient was managed very well, and she is now recovered. Her blood pressure is 85. Saturation is also coming up to 90%. Now her blood pressure comes to 100/64. So within that 1 hour, she is revived and managed well. This patient is now getting managed for coming to the routine ward. But we don't have Dr. Bharti here, I think. The first panelist, Dr. Jaimala, can take up this is that, now it's a retrospection. We have to introspect ourselves. What is this complication? She's already said pulmonary edema, but what went wrong right from the early pregnancy? How we have missed and mismanaged this patient?
I think this patient should have been counseled properly because she refused the admission and she left the hospital despite.
Yeah, Dr. Jaimala, I think I agree with you this, but then I'd say right from early pregnancy. If you say 36-year-old lady treated with IUI, so all high risk factors. Yes.
Yes. So she had
very high.
Yeah.
I think aspirin should have been
And such
started.
patients are at high risk for a postpartum cardiomyopathy, ma'am, because now after delivery, the heart has to pump against an increased preload because the uterine compression is gone and the increased afterload also. So everything is increased. The heart is struggling to push the blood that has been pumped into it. So there is high chance that she will go in for some kind of a system failure. So all the systems
right
will have to
Actually,
be.
madam is talking about lost opportunities. There has been poor antenatal checkup. She's elderly. She's IVF treated. Her gestosis score is quite high that way. She should have been under a regular antenatal checkup. What if her husband is not there? Somebody else could have brought her to hospitals for
Why
regular
not the
antenatal
obstetrician?
Low dose aspirin and
Yes.
screening. First
Right.
semester screening.
prophylactic aspirin and all those things should have been
High
started.
dose calcium. Yes, gestosis. Low dose aspirin and high dose calcium. Okay, 1.5 to 2 gram calcium.
Yes,
That's
that's the
one.
first thing should be done.
Yes,
First
should have been.
semester screening should have been done.
Yeah, so right. That is what I'm saying. They should have tried these women at 11 to 13 weeks. Go for the biophysical and the biochemical test as well. Nowadays you have PLGF and SFLT also in the metropolis. If it
And
is
even the
not,
diastolic notch also, no, ma'am?
yes,
High
yes.
resistance
You
treatment for
yeah,
also.
yeah. Right. Talk about the biophysical, Chitra. You can say that uterine
Ma'am,
versatility index.
Yeah, if the persistence of diastolic notch is that the patients are high risk for developing preeclampsia. So that is also one of the reasons where you have to start with at now low dose, at least 150 milligram of aspirin should be started.
So a combination
about the
of
dose,
tests.
we will not go into the dilemmas. They are saying that 75 milligram is the standard dose, but of course 1 milligram per kg, 1.5 milligram per kg. So if she weighs more than 70 kg, it is said that it should be more than 100 milligram. So below 70 kg, we keep it to 75 milligram of aspirin. That is fine. Calcium of 1.5 to 2 gram. That is also fine. Only thing is what we are doing, they have to go ahead with the biophysical and biochemical screening. That is there to go for the uterine artery pulsatility index as well. If she is high risk, and they have to put all this. And of course, the obstetrician should never say that everything is fine. Obstetrician has to say that you are at high risk. You have to be, come for the regular antenatal visit, because time to time you have to individualize her. You have to offer her some special investigation. So you need not tell the patient, you should not tell the patient that things are fine, and otherwise the patient can relax and lose to follow up, and she can land up into complications. So that is what. And then of course all of you know the way she has been mismanaged for as far as the antihypertensives are concerned. Right from the first visit, when she reported 176 by 116, what should have been the antihypertensive, Dr. Jaimala?
IV labetalol should have been the first line. But obviously, the patient refused admission, so they put her on oral labetalol, but that too a suboptimal dose.
So either it should have been capsule nifedipine 10 milligram, maybe 3 or 6 hourly or 8 hourly, that could have been better. Or maybe, the patient, at least tablet labetalol 200 milligram 3 times a day. Yeah. So the wrong way of, administration, and of course the wrong dosage schedule as well has worsened the situation, right? So we have already talked about all these pulmonary edema and all these things. So we will not discuss this theoretical aspect. We come to you, Dr. Anita, now. We have this 31-year-old third gravida, para 1 L1 with, actually fourth gravida, para 1 L1 with 2 abortions, previous abortion. Now she's 34 weeks gestation, and she's seen in the antenatal clinic with vomiting at 34 weeks. Okay. Blood pressure is 130/90. She has no proteinuria. Hemoglobin 8.5 gram%. Platelet count 70,000. SGOT 60. HGPT 76. LDH 600 international units. Anita, what is your probable diagnosis and how will you manage this patient?
Yeah, most probably, ma'am, she is heading towards HELP syndrome because her platelets are going down and her liver function tests, as far as enzymes are concerned, they are also going up. LDH is also high.
So what is the normal? What are the normal levels of liver enzymes during pregnancy?
Yeah, they should be
When do you
around
call
40
it?
OT. Yeah, OTPT for generally to remember it is around 40. So we have to be now very cautious. She is anemic also. We have to take care of her anemia also. Do regular monitoring for blood pressure. Hope this is the only reading and we will monitor her properly. And if she can have outpatient care treatment, but she has to be kept under close observation.
No.
Blood pressure has to be controlled.
Okay. Yeah.
Anemia has to be
She is a
treated.
case of health. There is absolutely no doubt. But health, you have to take it seriously. In fact, when you can catch the patient during early period, that is very good. But you should never leave her alone. Never. It is always a hospitalization and aggressive management. Now, I would go ahead, Dr. Sujata. Can you take up this discussion ahead? That how do you manage this case? 34 weeks HELP syndrome.
So it's a straight forward case, madam. It's a BP is not at all a criteria,
right?
For decide. So severity of the BP is not a criteria,
Right.
and also 25% of the HELP syndrome will not have any proteinuria also. Even 20% of the HELP syndrome, BP also will be normal. So we have to take all the hemoglobin is dropping, which indicates again a hemolysis. So and thrombocytopenia less than 1 lakh, severe. So my opinion is you give her a shot of steroid and deliver immediately with blood and blood products.
Right. So we understand that you want to give steroid. You have your concepts clear. But for others, I would ask you, what is the role of steroids here? Whether it is therapeutic for this patient and how much is the dosage? What is your take on this?
So this 34 weeks, actually steroid, it's not a hard and fast rule, but you can give the first dose of steroids. And even the first dose
you mean to say
will
steroids
help.
For antenatal steroids for lung maturity?
Yes, that.
Okay.
And also
it can also help in platelet
activation also.
They
Platelet count
have
also.
the idea that it helps, but it is not
Proved.
proved.
It is
Proved
not proved.
Evidence based. It's not evidence based.
Let us not go into the controversy first. Whether it is antenatal steroids for lung maturity or you want to say as a treatment of health.
Lung maturity, ma'am.
Clarify.
Only lung maturity.
Sujata. Yeah.
Only lung maturity. Not
Okay.
for HELP syndrome as such.
Yes. So suppose, there are some school of thought that, HELP, if you have rapidly progressing HELP, when you want to stabilize this patient and, you don't want her platelets to go down or the bilirubin to rise high, that you have what is called as therapeutic steroids, where, though it is controversial, just to kill that time of 24 hours, you get a window of opportunity where you don't want the platelets to go down. Here you have, 30 milligram of dexamethasone intravenously, and there are many studies. So that they have proven that, it definitely arrests the thrombocytopenia, and in that period you deliver. HELP means deliver. You don't have any other option, correct?
Yes, madam. There are two school of thoughts, and actually steroids can be help in the HELP syndrome, and also in the cerebral edema cases. So at least 12 milligrams should be given, more than 12 milligram.
Yeah. So it will help for both ways, even for fetal lung maturity also, right? So this patient you have to deliver. So naturally, what are the problems here in HELP? How do you face these problems? How do you tackle these problems?
So HELP syndrome is something, sometimes we land up in a soup. Actually, platelet, when it is lower level, below 1 lakh, we should be cautious. When it because less than 80,000, very difficult for a regional anesthesia. They say at least you have to maintain around 70 to 80,000 should be maintained. So better you terminate when you falls below this level. And for vaginal delivery, at least 50,000. So better to arrange for platelets, and also you look for the DAC profile also, PT, APTT, BTCT, and fibrinogens. And you give, we usually reserve the blood products. And we repeat the coagulation profile until she delivers. Every 8th only we will be repeating, and under constant monitoring, and we will be delivering with the reservation of blood.
So I would
blood
ask
products.
Dr. Chandrakala, is there any specific management for HELP? Can you prevent HELP syndrome? Dr. Chandrakala, please unmute yourself. I think I could see Dr. Sampat Kumari, Madam Sampat Kumari. I could see just now.
Yes. You proceed.
Yes,
I will
madam.
talk at the end.
Welcome.
Sneha, you proceed.
Yeah,
Panel is
thank
going
you,
on
madam.
fantastically. You proceed.
Yes. So I will invite you once we over with the discussion. Yes, Dr. Chandrakala, please go ahead.
Yes, madam. Madam, prevention of HELP syndrome is prevention of preeclampsia only. It is like prevention of preeclampsia as a thing, way out to prevent a HELP syndrome.
But madam, do you remember that just now we said that, 20% of the HELP syndrome, they do not have hypertension, right? Around 10% of these patients with HELP syndrome, they do not even have proteinuria. So HELP syndrome can never be prevented. That is a very clear-cut answer, right? And as we have just discussed, that even giving the steroids as a part of management, it is empirical. There is no documentation, no definite evidence. Of course, there are two schools of thoughts, as you said, but you can utilize that window of opportunity of 24 hours where you can have the the platelets going down. You can prevent the thrombocytopenia, right?
And it goes without saying, ma'am, we have stopped aspirin by then. If the patient was on aspirin, we have stopped aspirin.
Yeah, we have to. Right. So the role of steroids, see, this is 10 milligram intravenous dexamethasone every 12 hours, and then 10 mg every 12 hours. For 3 doses, that comes to 30 milligram. I have told you that every 12 hourly 10 milligram. So that likewise you give 30 milligram of dosage for this dexamethasone. So they say that steroids, they are not curative, but they give you the window of opportunity where the platelets do not deteriorate, the platelet count do not go down further. So that is a period where you have to deliver the patient as soon as possible. So what is the ultimate management for HELP?
Immediate delivery.
Immediate delivery, definitely at obstetric HDU or ICU. And then we go ahead with the next case now. We have this patient named ABC, 22-year-old female. She was admitted from OPD 20th November 2009, and it's a case of primary full-term breech and severe preeclampsia. Okay, so this patient, she has taken regular antenatal care, and she has passed cystic pulmonary COX 2.5 years ago. Her blood pressure is 160/110. Her rest of her examination and things are, general examination is normal. Only thing is she's got breech presentation, and on per speculum exam, she's got breech presentation, fetal heart is good, contractions 40 to 45 seconds every 3 minutes, that is 3 contractions in 10 minutes. And spontaneous rupture of membranes occurred. Liquor is clear. This patient was 7 centimeter dilated, fully effaced breech with foot felt. Membranes were absent. And this is the investigations where everything is normal. Okay. And she delivered full-term assisted breech delivery, 2.6 kg baby. This is the timing. Everything is fine. Placenta membranes delivered intact. Episiotomy was sutured well with 1-0 chromic catgut. At the time of delivery, there is a PPH. Okay, so continuous massage is given. Whatever management we are doing routinely, oxytocin 20 units, prostudine 1 ampoule, injection tranexamic acid, 1 Paxil, the PCV is also started. So this patient, she had all her investigations still otherwise normal. CBC is normal, but bilirubin going to 3.9, and of course liver enzymes are rising now. And on the second day, the urine output is nil in spite of giving injection Lasix twice change of catheter, everything has been trying. The fast IV fluids are also given. What is your diagnosis here? I think Dr.
Acute kidney injury.
Acute kidney
AKI.
failure.
Yeah. Acute kidney injury following.
I can see Dr. Bharti. Dr. Bharti Rajsekhar. Are you here? Dr. Bharti?
Yes, Dr. Sneha, I'm here.
Yeah. So this is
We
a case
lost a
for
patient
you.
recently this way,
Did you
ma'am.
hear the case?
Yes. No,
Yeah.
I was just joining now, so I will just go through the
Okay.
findings. Give me a minute.
So you have this primary. Let me check. Yeah, you have this young primary. Initially she presented to you as full-term breech with severe preeclampsia. Okay. Her BP is 160, 110. Rest of the things are normal. Uterus is full-term breech presentation. Fetal heart is regular. She's got contractions 40 to 45 seconds every 3 minutes. And spontaneous rupture of membrane occurred. Liquor is clear, and she's 7 centimeter dilated, fully effaced. Breech with footling felt. Okay. And she delivered the breech. Okay.
Yeah.
Episiotomy sutured well. At the time of delivery, there was little PPH. They have managed her baby. Plus Paxil volume also given. And after say around 12 hours, they find that the PP is still 150-100. Urine output nil in spite of giving fast fluids, IV Lasix, and change of catheter, everything. So what is your diagnosis? How will you manage this case?
Well, thank you, Dr. Sneha. My apologies for being a little late.
No
Well,
worries.
probably she's gone for an acute kidney injury, and her hypertension may have led to the hypertension may have led to an acute kidney injury, like renal cortical necrosis, and probably that is the reason for her absence of any urinary output. And the other possibility, she could have had a little sepsis also.
Okay, so her ultrasound finding USG and KUB was done. Both the kidneys approximately normal size, but mildly increased echogenicity. And X-ray chest, showed a blunting of left chippy angle suggestive of left-sided pleural effusion. USG abdomen pelvis shows liver enlarged, and 4 platelet packs were given to her. Okay. So nephrology reference was done because in spite of trying everything, she was not having any urine output. Okay. So strict intake output chart, APG, gas analysis, RFTs and electrolytes, everything was done. Only in these investigations, otherwise there was no abnormality. Okay. Even the serum creatinine was 2.18. That was the only abnormality here. And the peripheral smear showing microcytic hypochromic anemia and anisopoikilocytosis. So what is this indicative of? Once again, serum creatinine 2.18.
Her hemoglobin also seems to be reducing.
Yeah.
It was 10 and now it says it's 7.6.
Right.
Yeah.
So what are the chances of renal failure in such type of preeclampsia, and what are the causes for ARF? Whether it is acute renal failure, acute kidney injury, how to make the differential diagnosis of HELP and HOS, hemolytic uremic syndrome. These 3 conditions are very close, right? HELP, I think we discussed this point more, that HELP, HOS and TTP. How do you differentiate it?
Well, the one is in HELP syndrome, the low platelet count will be there. There will be hemolysis, and so you'll have the low
that will be there
platelet
in
count.
thrombocytopenic purpura also, thrombotic.
And in HELP, you will have the bilirubin, the liver function tests.
Right.
Your SGOT, SGPT will be elevated. So that is one point which will point towards the HELP syndrome.
Right.
And the other parameters like her hemoglobin, hematocrit will be high, and along with that, her coagulation factors may be prolonged in the case of HELP syndrome.
Right.
Neurological symptoms in TTP, ma'am.
Yes, that is what is most important, because hemolysis and thrombocytopenia will be common in all the 3, if I say so, right? So these are mainly the neurological symptoms which are very prominent in TTP, right? And of course, the renal impairment will be more hemolytic uremic syndrome. The patient goes in uremia. hemolytic uremic syndrome, the renal parameters will be more worse, and whereas HELLP, the liver manifestations will be more severe. Right. What about AFLP, acute fatty liver of pregnancy? How do you differentiate this condition? If at all you suspect.
The random blood sugar levels will be
Yes, Dr.
constantly
Sujata.
low.
Hypoglycemia is there.
Yes, hypoglycemia is the most prominent feature here in acute fatty liver of pregnancy. So I'm sure all of you you got it, because in TTP and HUS, the microangiopathic hemolysis, thrombocytopenia, acute renal failure, and neurological abnormalities. All these things are common, but neurological abnormalities will be more severe, more predominant in TTP. That is what you have to keep it in mind. So I don't think we should go into this theoretical aspect, but then definitely this patient needs to be shifted to
a nephrology unit.
Yes, definitely to a kidney unit. So on 4th day evening, this patient, she had a urea 68, creatinine 4.3. So she was transferred to kidney unit 5 times. Hemodialysis was done for total 4 blood transfusion and 6 PRC given at the kidney institute. Okay. So renal biopsy under USG guidance was done. So report was acute cortical necrosis, thrombosis of cortical vessels, no parenchymal tissue seen, hemolytic uremic syndrome. If microscopy, no immune deposits were seen. So post biopsy, there was no evidence of any peripheral collection. This was the biopsy report suggestive of acute cortical necrosis. Now, I will just ask you why this has happened. All of you are well versed that why this patient of severe preeclampsia or severe hypertension lands up into, initially it lands up into acute tubular necrosis.
Yes.
And that is a reversible one. But once you do not intervene here, you timely and appropriate intervention makes a lot of difference. But if that phase is missed, then this patient can go into acute cortical necrosis, from where it becomes really irreversible. And that is why the patient lands up into dialysis and all these problems. Right. So the creatinine values now they are coming back to normal, and on advice and at discharge, she was advised hemodialysis at 4 to 6 days interval, to wait for another 15 days for improvement. And if no improvement is found with this duration, then get the renal transplant done. See, simple things, how they become complicated. So what do you suggest in this patient? What has gone wrong?
So probably there has been a delay in identifying her problem of the kidney injury.
Right.
And she should have probably been seen by the nephrologist a little earlier, so we could prevent the acute cortical, and this loading of Lasix could have led to a cortical injury. So we should have probably got her controlled, blood pressure controlled adequately, and then referred early to the nephrologist for dialysis.
Right. Things are fine, Dr. Bharti. One more additional thing, if I tell you that she had suffered PPH. So
that was
maybe the PPH was not diagnosed early and not managed effectively. So that hypovolemia has added to the damage, and took her from acute tubular necrosis to cortical necrosis.
Intravascular compartment has to be really taken care of, because these patients should avoid any kind of dehydration or hypovolemia.
Right. So now we go ahead with the next case now. Let me, So I think we just finish up this case fast, and we stop our discussion now. 21-year-old Pyramid Gravida, 34 weeks pregnancy, an uneventful antenatal course, and she's brought she's brought in an unconscious state with the history of one episode of convulsion. BP is 210, 114, and she's 3+ proteinuria. She's not in labor. So, Dr. Rashmi, this is the last case for you, and we wind up. What would you do in first 10 to 15 minutes? What is the diagnosis, by the way?
This is a case of, most probably it could be a case of eclampsia. As soon as we see the patient, we have to immediately start with the airway has to be maintained. We have to prevent the tongue drop, and start an IV line, catheterize the patient. Then you start the patient on Maxil. You go for the Pritchard regime, 4 grams IV, and then 5 grams in each buttock. And then you have a check the BP. Put the patient's BP is around 200, 140. You have to start her on IV lebetalol if required. Then you have to go for blood investigations. All the basic blood investigations for PIA, for eclampsia, has to be done.
Yeah.
And
then only one point here I would like to say that before you give magnesium, sir, you put in 2 IV lines. From one side you start giving Maxil, but from the other side ask somebody to collect the laboratory investigations, right? Right. Okay.
And then you need to consider termination in mind. Once you stabilize the patient, then you should go for termination.
Yeah. Unless you stabilize the patient, don't even put the catheter, I would say, right?
Yes, before you do that. You do the stabilization before the catheterization. The magnesium has to reach first.
Right. Because, okay, so now how do you assess this patient? How do you monitor this patient? And then what are the principles of management? I think this is just I mean, somebody can just say it out as a revision.
Treatment of seizures is different than treatment of hypertension and expedite plan of delivery. That is the summary I can say. These are the 3 points which have to be taken care of.
I think you need to concentrate 3 things: general measures, specific measures, and obstetric measures.
Right, perfect. So general measures, you talked about the antihypertensives and anticonvulsants. So what is the general measures, Dr. Chitra?
What you mentioned the starting, no, ma'am.
Yeah.
The airway, breathing, catheterization, suction,
Right.
preventing the injury. The specific is regarding the antihypertensives, anticonvulsants for the patient. Obstetric is planning the delivery, immediate delivery, which is very important for this patient.
So depending upon the fetal and the maternal conditions and the inducibility, you have to take a call whether regarding the timing and the mode of delivery, right? So just ask one question and we'll stop.
Madam, I would like to add.
Yeah, please.
If there is a prolonged post-ictal state or focal neurological deficit.
That is what the question I'm asking.
Yes.
I'm asking. That suppose you have given her, she is convulsed and she is, not regaining her consciousness. That is one situation I want to know from you. And secondly, in spite of giving the full loading dose, she is convulsing again.
Yes.
I think the second person answer first. That you have given a full loading dose, and in spite of that, within 10 minutes, she's convulsing again. What should we do?
Ma'am, first because within 15 minutes means we really need to check our blood pressure again, because it is a gap of 15 minutes. So Maxup doesn't prevent excess hypertension, but it doesn't prevent. So if it is necessary, BP is still high, you have to give additional doses of antihypertensives. Then if at already full dose is over, you can give additional dose of Maxup also, 2 grams for this patient.
Right.
That is within 15 minutes.
Yeah, but if she convulses, suppose she convulses after half an hour, then you need to give 2 grams.
Yeah, then you need to give that 2 grams.
If she convulses within first 10 to 15 minutes, you need not give her repeat dose of magnesium. Wait for another 15 minutes. But if she convulses after half an hour, then definitely
we have to give the repeat dose of magnesium. Yeah.
Even if you give repeat 2 grams, suppose she convulses again.
Then you need to go for benzodiazepines. We can give.
Now, what is
you have to sedate and go for intubation. Sedate
and you have to rule out other causes of convulsion. And then, you have to identify whether she has any other intracranial lesion which is causing her.
Right. So in other words, what are the indicators? What are the indicators that will guide you that she's landing up into intracranial complications?
Patient will have drowsiness, unconsciousness, blood pressure.
Right.
Recurrent convulsions, coma.
One is not regaining the consciousness to that.
Prolonged post-ictal state, focal deficits will be there.
Focal deficit.
Focal neurological deficit.
And
That's
no
neurological deficits are the clinching point.
and
the
recurrent
level of
conversions, that
consciousness is very
status
low.
in spite of magnesium sulfate, right?
Yes.
Yes.
So this is how then you need to involve your neurologist friend, definitely. So I think we have covered almost all the aspects. There are few cases of acute respiratory failure and all this. So I would just say that I thank all the panelists for your wonderful inputs. The panelists are very well read, and I would thank the organizers for having us here. And I just take this opportunity to make a humble appeal to support my candidature as Foxy Vice President from West Zone for the upcoming elections. The voting process will start soon from 1st to 10th August, and the voting is online. For West Zone, there are 2 posts. I request you to make me as your first choice. So thank you so much, all of you.
Thank you, Madam. Dr. Sambat Kumari, Madam, is with us.
Yes,
Madam.
yes, definitely. I'm going to request, Madam, to please express your feelings and, of course, guide us. Definitely, we are very happy to have you, Madam. Welcome once again. Over to you.
Neha, very sorry for joining at the last minute. We had some easy meeting. So small
Yes,
discussion
happy to
regarding
have you,
our
Madam. No
conference.
worries.
Okay, so wonderful panel. First of all, Sneha. So I missed the talk of Ramani Madam and Shanti Ranis, but you did a wonderful panel. And our coordinator Priya Kannapan was telling from yesterday, Madam, you should join at least for 5 minutes, 5 minutes. So finally for Sneha, I have joined. I request all of them to vote for Sneha. Really, she is a hardworking, sincere, and that is the reason I joined. So, Sneha, you will become a vice president, and as a vice president, you should come to our Chennai society first.
Definitely,
Okay?
we'll celebrate there.
Then Bharti Rajshekar will be the committee chair, committee chair.
Yes.
So she will also do
Thank
her workshop in our place. Chennai
Thank you,
society.
Dr.
Okay?
All the best
So
wishes,
all
ma'am.
the best to whoever is contesting. Chitra is in Pondicherry. She is having her own world. She is not bothered about any society, any committee, or anything. I have repeatedly telling her, but she is not listening to me.
Ma'am,
We will go.
Because, ma'am,
We will
I
go
need
to
your
Pondicherry.
blessing.
ma'am, I'll support in whatever you're doing. I'll really support. Serious, that's why I
Chitra,
told Sneha ma'am and now
See,
we will
Bharti
come
ma'am.
Anita,
to
So
now Anita
Pondicherry.
is there.
Thank
Everyone
you,
is
ma'am.
contesting. Why, Chitra? You are working in a prestigious institute, Zipmar.
I
You
know.
should contest, no?
ma'am,
Yes.
it's Jippa's very busy, ma'am. Don't have time for other things. To be
No,
frank.
as if we are not doing. We are sitting in
Ma'am,
the
I
house
know.
and eating you people.
not like that. Okay, I'll talk to you, ma'am.
No, Chitra,
So,
you
Yes.
should become a committee
Sneha,
chair. We will have it.
I
Yes,
think
anyway,
once,
all the best. Wonderful webinar. You do continuously with the TNFOG, Sneha. We
yes,
had a wonderful opportunity, and definitely you will win. And my support for all the persons who are contesting, Bharti, Anita,
Thank you.
Sneha, and everyone.
thank you, ma'am. Thank
All
you
the
so
best.
much.
Thank
I
you.
would
Thank
seek
you.
Madam.
blessing of others, all my dear friends who are there in the panel and whoever they are there in the faculty. Bharti, good luck to you.
Yes.
Sneha,
Thank you,
ma'am,
Tim.
best wishes.
All the best to
May
all of you, my dear Dr. Bharti and
Thank you.
Dr. Anita.
Thank you, Dr.
Of course,
Sneha.
Madam Ramani Devi. The talks were wonderful. Sampath
Yes.
Madam, let me inform you.
That is
Ramani
the
Madam's talk is always, it's such a
Yes.
pleasure to
It's
listen
always
to
very,
Madam.
very, very.
And Shanti Rani has, done it wonderfully. So I'm very happy.
Ma'am, even you have a well-moderated session, ma'am. If no one
Yes.
has
Sneha.
just come and said
Yes,
everything is covered with your
Sneha, I
panel.
want to have a word.
Madam?
A beautifully moderated panel on
Dr. Anjali, Madam.
preeclamptic crisis. Very
Madam.
nice. Everything you have
Madam.
brought out very nicely. So
Thank you,
congratulations
madam.
and my best wishes.
Thank you,
Okay,
madam.
before
Thank you.
that, no,
In fact,
Sambat has taken the chance to actually to congratulate you as well as to wish you. Okay. Yes,
Thank
Anjalakshmi
you,
madam.
madam. Thank you so much. In fact, initially only I said that we started our series with TNFOG long back, that when I was
Yeah.
a committee chairperson.
Yeah.
He and Kalpana has taken, such a long series, breast committee, infertility committee. And I'm so happy that, TNFOG has given us a chance continuously for 3 years. I'm really thankful to all of you, madam, Ramani Devi,
All the best.
Kumari, and
All the best, Anita.
Thank
And
you.
Madam, I,
Thank you,
Dr.
Sneha.
Bharti
Bye,
Rajshekar,
bye.
I request
Ma'am,
all
Anita
of you
ma'am,
to
when
kindly
Anita ma'am is contesting, so madam, all the
support
best wishes. Our support is
Thank
there
you.
for you
Thank
also.
you.
for
Sure.
me
Best
also,
wishes.
Dr. Bharti,
And
for
Dr.
telling
Bharti,
it
madam
all
is
in the
there.
Bharti,
committee.
let her
Dr.
tell.
Bharti, madam, you want
Bharti,
to
you
say
tell.
something?
Yes. I request I request all my TNFOG